Good evening. It's a great pleasure to meet you all again this first month of this year, 2024, and it will be the first session for this year. We have an interesting session ahead. We have a postgraduate session where we have two presentations from two postgraduates. Then there will be a review of literature on Crohn's disease, followed by we have an interesting CME which is also coming up. So I welcome you all to this next edition. I'll request President Dr. Eapen to provide his welcome address and some interesting tidbit of information that he usually gives us. Thank you.
Thank you, Perumal. So welcome to the first monthly meeting of this year. And I think incidentally it will be the last in my capacity as a president when I'm coming to Chennai. So in Madurai meeting, I'll be finishing my tenure as presidentship and waiting for the next handover. So I thought I'll make a little serious cartoon today in view of the gravity of the situation. So this is again a cartoon, but it's not a funny cartoon. It's a cartoon we can be proud about, really. So this just tells us the journey of this rodenticide poisoning and the part TNISG has played in this. It really is phenomenal, actually. And I don't think any of us planned any of these steps and how it happened just in the last 2 years or 3 years. So the Tamil Nadu ISG multi-center study was conducted in 2019, Jan to June, and got published. It took 3 years to get published because the journals where we sent it to did not see it as a problem. So the need for a local journal which realizes what is a problem here is very crucial. And very soon we brought out the guidelines from TNISG on managing rodenticide poisoning. And again, so it's come out in the GHEP journal. So once we conceptualized it, within 6 weeks we could bring it out. So we proposed in that a series of steps to be taken. And within 6 weeks, lo and behold, the government of Tamil Nadu implemented that. So that's again, it's unforeseen. No one thought it will happen like that. By various chain of events, really. So that moved on to, this whole cartoon is made from the government office of NHM, National Health Mission. So they only have made it to say that how online training of the different teams happen in different medical college hospitals and different primary, secondary and tertiary care centers in the government sector. And how there was a visit to Tanjavur where in our study the highest number was in Tanjavur. So the site visit was made, a video documentary was made, which was, I think, played in the secretariat, I think. And the government passes GOs taking this forward. And in the course of the year, in 1 year, 652 patients under the government's system in National Health Mission undergoes plasma exchange for rodenticide. In the same year, the number of people who underwent urgent transplantation across Tamil Nadu in government and private sector for rodenticide was 2. So that is the difference. So it's really nice. So this is the only other slide I want to show. And in the guidelines, we brought out some indications for plasma exchange in patients with rodenticide hepatotoxicity. And this, to date, remains the only guidelines for indications for plasma exchange in the whole world. Now, we are not saying it is for acute liver failure. We use it specifically in this scenario of rodenticide poisoning, but this remains so. So I'm saying it's really nice that such a step happened. So the multi-center study enabled this to happen. Our journal enabled this to happen, and all of us working together. So I'm sure that there are many such moves we can do ahead. So thank you, and let's move on to today's meeting.
Thank you, sir. We move on to the postgraduate session. I request chairpersons, Dr. Murali, Dr. Porselvi, Dr. Rajesh, and Dr. Adarsh to conduct the proceedings, please. Thank you. So, Dr. Porselvi is a consultant at Apollo Hospitals. Dr. Rajesh is a consultant at SRM Medical Institute as well as Tambaram, SRM Global. Dr. Adarsh is at Kamakshi Hospital right now, and Dr. Murli, the senior most person, is our professor and head at Miyot Hospitals. Thank you, sir.
Thanks to, good evening to everybody. Thanks to ISG Tamil Nadu chapter for giving us this opportunity to share the postgraduate session on the first meeting of the year. I request the speaker, Dr. R. Deepak Kumar from MMC, to give his presentation. Topic is Silent Invader.
Good evening, everyone. This case is about a 26 years old female from Vaniambadi who is a homemaker. She came with the chief complaints of vague abdomen pain for the past 7 months and abdomen distension for the past 1 month, with history of loss of appetite and loss of weight for the past 1 month. History of abdomen pain, which was for the past 6 to 7 months, on and off pain, diffuse and dull aching. On a pain scale, it was initially mild, then it progressed to moderate in intensity for the past 1 month. Pain was partially relieved with analgesics. Pain was not radiating. There is no relation with any food intake or defecation. History of diffuse abdomen distension for the past 1 month, which was insidious in onset and it was rapidly progressive over 1 month. It was not associated with respiratory distress, no facial puffiness or any reduced urine output. History of loss of appetite was present for the past 1 month. History of significant unintentional weight loss also was present for the past 1 month. No other significance complaint to the patient, no altered bowel habits, no fever or vomiting, no cough with expectoration, no EC fatigability, no history of any yellowish discoloration of eyes and urine, no history of any hematemesis, melena or bleeding PA. No significant comorbidities in the past. She was treated for abdomen pain with analgesics on and off for the past 6 months. She was not on any other regular medications. There was no significant history of any malignancy in the family members, no contact history with any TB patients. Personal history, she consumes mixed diet, there is no addictive habits, she is married and has 1 female child, and her menstrual cycles were regular. And to summarize, this is a 26 years old female who presented with a dull aching, diffuse abdomen pain for the past 6 to 7 months. Then she developed rapidly progressive abdomen distension for the past 1 month with the loss of weight and loss of appetite. Then we proceeded with a clinical examination. On general examination, she was conscious, oriented afebrile, moderately built and nourished, no pallor, icterus, cyanosis, clubbing, lymphadenopathy or pedal edema. There are no signs of any liver cell failure. There are no cutaneous markers of any internal malignancies. Her vitals were stable. Her BMI was about 21.4. On per-abdomen examination, on inspection, generalized distension was present with flanks full. No other positive findings were noted on inspection. On palpation, mild tenderness was noted in both right and left iliac foci. On percussion, fluid thrill was present, and on auscultation, bowel sounds were present. Per rectal examination, it was a normal tone. No mass was descending per rectum. No deposits were noted in the pouch of Douglas. At this juncture, it's a young female with abdomen pain for the past 6 to 7 months, with a rapidly progressive abdomen distension for the past 1 month, with a loss of weight, with a significant loss of weight and loss of appetite. Then on examination, she was found to have a grade 3 ascites. Possible DDs we thought of at this junction was either TB abdomen or any abdomen malignancies. Then we proceeded with investigations. Complete blood count was done, HB was normal and other hemogram parameters were also normal. Liver function tests were normal apart from total protein which was reduced and it was 5.2 and hypoalbuminemia which was about 2.9. Renal function test and serum electrolytes were normal. She had dyslipidemia, total cholesterol was elevated and it was 316 and HDL was slightly reduced and it was 34. Coming to ascitic fluid analysis, it was a blood tinge yellowish color fluid with low SAG and high protein ascites. LDH was elevated and it was 860. RBCs were noted in the ascites and ADA was negative. Coming to cytology, it was a lymphocytic predominance ascites. Tumor markers were markedly elevated. Serum CA was increased, which was 620, and serum CA 99 was also elevated, which was 170. Coming to cell block, it revealed a metastatic carcinomatous deposits. Coming to imaging, this ultrasound abdomen was done 2 weeks prior to admission, which showed a focal wall thickening in the distal transverse colon for a length of 8 to 9 centimeter with a surrounding fat standing and omental nodularity. Mild ascites was noted that time. Bilateral adnexal lesions were noted with a possibility of ovarian deposits. Colonoscopy was done, scope was passed up to ascending colon. There was a long segment circumferential thickening of transverse colon with a significant luminal narrowing. Transverse colon and ascending colon mucosa appeared unhealthy with ulcerations, and biopsies were taken and sent for HPE and CBNAT. With these findings, we thought it would be a colonic stricture, possibly secondary to malignancy or any tuberculous etiology. OGD was done, which showed a corporal gastritis with lax LES. There was no malignancies noted in the gastric mucosa. CCT abdomen and pelvis was done with rectal contrast, which showed a long segment circumferential wall thickening in mid and distal transverse colon for a length of 7 to 8 cm with a maximum thickness of 12 mm with moderate luminal narrowing with a proximal passage of rectal contrast with surrounding fat standing and subsymmetric paracolic lymph nodes and omental nodularity. Bilateral ovaries shows heterogeneously enhancing mixed solid and cystic lesions, and massive ascites was noted this time. With all these findings, we were given a possibility of malignant growth involving a mid and distal transverse colon with moderate luminal narrowing with omental and Krukenberg's deposits. CT chest was done to rule out any metastasis to the lung, and it was normal. Here in the CT, we can see an axial section and coronal section of the CT abdomen, both showing a significant circumferential wall thickening in the mid and distal transverse colon. Red arrow indicates the patient has a gross ascites. This another axial section of the CT shows omental nodularity suggesting of omental deposits. This is an axial section of the CT pelvis. It shows a bilateral heterogeneously enhancing mixed solid and cystic lesions suggestive of ovarian deposits. Meanwhile, we got the HP report of this patient. Multiple sections were studied which showed fragments of colonic mucosa with an infiltrating malignancy arranged in sheets composed of round cells with an abundant mucin with peripherally pushed pleomorphic dark stained nuclei. Intervening stroma showed as scattered lymphocytes with thin walled congested blood vessels. All these findings were suggestive of infiltrating adenocarcinoma of poorly differentiated grade. CBNAT also report was negative. This is the HP slide of this patient. We can see the tumor cells which is of poor differentiation because there was no gland formation in the slide. On higher magnification, we can see individual tumor cells which are filled with mucin, because of which the nucleus is pushed towards periphery, giving appearance of signet ring morphology. Immunohistochemistry was done to differentiate between a primary colonic malignancy from any metastasis to the colon. SAT-B2 was done, and it showed a strong nuclear positivity in 50% of the tumor cells, and it confirming and infiltrating adenocarcinoma of colon. So a final diagnosis was primary adenocarcinoma colon of poorly differentiated grade with a signet ring morphology, and according to TNM AJCC, it was classified under stage 4A. Then patient is being treated with palliative chemo, capox regime of capecitabine with oxaliplatin. This is an article which was published way back in 1967. Similar to our case, this is a case report of 24 years old female. She had altered bowel habits with bleeding PA that time. Then she was evaluated further, and she was found to have a primary serous carcinoma of colon with ovarian deposits suggestive of Krukenberg's tumor. This is another article published in 2022. This is a retrospective case control study published by Taiwan University. The study is on the characteristics of primary signet ring cell carcinoma of colon and the rectum. This study was done between 1993 to 2018. In this study, out of total 11,515 cases of colon cancer, only 18 patients were presented with primary signet ring colorectal cancer. The prevalence rate was only 0.16%. The mean age was lesser in signet ring group than compared with the non-signet ring group. Signet ring group patients had higher levels of CVA and low levels of albumin. Majorities of the signet ring tumor configuration was either ulcerative or infiltrative. Most of these pathologies were high-grade carcinoma with lymphovascular invasion. The signet ring patients were either diagnosed at advanced stage. Higher mortality was also noted in the signet ring group patients. So compared with non-signet ring cell colorectal carcinoma, signet ring colorectal carcinoma tends to occur at a young age, presented with serous appearance and poor differentiation, with more lymphovascular invasion and peritoneal involvement, with a poor overall survival. So on a take-home message for young patients with a colonic long segment stenosis and ulcerative and infiltrative mucosa, but if endoscopy failed to identify any malignant cell, primary signet ring colorectal cancer should be considered. Even with our progress in current chemotherapy and target therapies, there seems to be limited effect in survival of this patient. We still need to work out on these novel therapies to improve outcomes of these patients. Thank you. except for abdomen. Yes, sir.
No colonic symptoms, so the history is wrong. You've got the history, but got that.
But
The history is missing there. Okay, such a long segment lesion.
yes,
It's not possible that the patient had no symptoms, a change in bowel pattern. Number one. Number two is, of what interest is it to us for chasing the primary? Of what interest is it to us for chasing the primary in this patient? You already established metastatic.
yes, ma'am.
So why should we chase? When will you chase a primary?
When we are able to treat the patient.
And the stenotic. So how will you know that whether it's just the fluid that has got metastatic lesion, it's actually infiltrating the colon because it's a long segment
Yes, ma'am.
with no symptoms.
Yes, but it was no.
Okay, there's no symptom. So when will you consider? How old is the patient?
It was 26 years old.
26. Now what is the hereditary? Have you done genetic studies?
Genetic
Why
studies
is it
was
important?
to counsel the family members.
For what? Why
Yes.
is it important in this patient? 22-year-old lady with if you say it's colonic cancer.
Yes, ma'am. We can counsel the family members, ma'am.
For what? Which are so that's the message you should have given us. What
Yes,
the bottom line is, when I'm not interested at all in this. No, the interest is what will be the genetic profile in this patient? Is it KRAS mutation defect? Is it MSI?
MSI, MMR, KRAS, and
so
then
that's
this.
all theory.
Yes,
But that genetic study is the most important component of this particular study, because in the family members, you should know when to start screening them.
yes, ma'am.
They are at high risk.
At least
And
we
once
should
you-
do a MSI or MMR.
So the history is, no, what I'm trying to tell you is the history is wrong. No? Long segment, transverse colon, descending colon, and patient has no symptoms. So we have missed the history there. And it's an advanced stage 4 disease. I would not go for a CT chest and all that. If this was in a corporate hospital, the patient would have spent $1.5 lakh or even more than that. A patient with stage 4 disease, would you go for a CT chest and further workup for further clarification of what's the origin of the tumor? Doing an upper GI endoscopy and then doing a colonoscopy and then doing a CT chest. Then some people would even gone for a PET CT. For what? Ultimately, we are still at the bottom line, we are with the just same basic treatment.
Palliative.
It's just palliative.
Yes, ma'am. Yes.
If you did not have a primary lesion which you really don't know, then you could have gone for this. Otherwise,
Any other questions, please? You want to ask him?
So colorectal carcinoma is on the rise, ma'am. Yes, ma'am. Yes, ma'am.
You already reached a stage where ascites has come.
Yes, ma'am.
You missed the diagnosis from history taking. Had you picked up the change in bowel pattern, she would have survived.
She presented to us with ascites, ma'am.
Saying is somewhere
But
down
before
the
that,
line,
yes,
somewhere
ma'am.
down the line, what's the
ma'am.
duration? What is the bowel pattern in this patient?
Bowel pattern was normal, ma'am.
How is it possible this patient has a normal bowel pattern? No, history wise. She says bowel pattern is normal. Is it possible with such a stenotic lesion? History is most important. If you had
Yes, ma'am.
picked up the history, you would have picked up what's the diagnosis and even the primary. Intake would have definitely decreased. At least she'll have secondary constipation, if not primary.
Okay.
Dr. Murli will always say the most common cause of constipation is secondary to lack of eating. So don't put a colonoscopy. Do the upper GI whenever there's constipation. That's one thing I always learned from him.
Okay, we'll go to the next, please.
Thank you.
The next case, the speaker will be Dr. P. Muthukrishna from SIMS Hospital. He is going to tell us about mind the sump.
Good evening, teachers and friends. Today I am going to discuss about an interesting case of acute abdomen. My title for the case discussion is the mind the sump. Here we have the patient of a 69-year-old gentleman. He came to emergency department with upper abdomen pain since 2 days. History of presenting illness. The acute abdomen, the upper abdomen pain for 2 days, which is acute onset, continuous in nature, epigastric and left hypochondrial. Pain scale of around 7/10. The pain is radiating to the back. Pain not related to food or defecation. It associated with 4 to 5 episodes of non-bilious vomiting and non-projectile. This is abdominal pain not subsided after vomiting. There is no abdominal distension, no history of fever or jaundice, pruritus or clay color stools, no history of dyspnea or oliguria. He had a similar episode 6 months back, for which he was treated as an outpatient nearby hospital with oral analgesics. There is no history of weight loss and loss of appetite. The past history, he had a significant past history. In September 2011, he had acute anginal pain, for which he was admitted outside hospital. They diagnosed of RCA block, they diagnosed of CAD as well as moderate LV dysfunction. Again, he was admitted another hospital in February 2012 for empyema gallbladder, for which they operated laparoscopic subtotal cholecystectomy. The post procedure, he developed biliary leak. One of his son told they tried ERCP, but it was failed. 2 months later, they did a hepaticojejunostomy, open hepaticojejunostomy. In November 2020, he was admitted in CMC hospital for chest pain. They did a PTCA for RCA and LCX. Then he had a significant aortic valve stenosis. They did a TAVR. He is a known case of diabetes, hypertensive, and benign prostatic hyperplasia on regular medication. And personal history, he is not a smoker and not an alcoholic. The drug history is in clopidogrel 75 mg afternoon, Rosaval 10 mg at night time, eplerenone 25 mg at morning, Silacar 5 mg at morning, Ditar 10 mg at morning, Digoxin 0.25 1 OD, and Eliquis 5 mg BD twice daily, and Jammer 1 tablet and morning. Rosuvastatin, ma'am. Yes. Okay. Yes. Rosaval, rosuvastatin, ma'am. Eplerenone is the same. Eplerenone was the same. Aldactone, eplerenone. Silacar, cilnidipine, ma'am. Yes, ma'am. Yes. Okay, ma'am. Silacar is the calcium channel blocker. Cilnidipine, Ditar is a torsemide, Digoxin, Eliquis, Abixaban, and Jammer is glimepiride 1 mg plus metformin. Okay. And vitals, BP is 140/90, pulse is tachycardia 114 per minute, SpO2 98% at room air. And general examination, he is dehydrated, and abdominal examination is right subcostal oblique scar was present. The tenderness present in the right hypochondrial and epigastric area. Bowel sounds are there. His lab shows hemoglobin of 17.8, hematocrit 51.7, WBC 9,280, platelet count is 2 lakhs, creatinine 1.5, little bit in a higher range, sodium is 125, potassium 4.5, total bilirubin is 2.4, predominant direct 2.1, indirect 0.4, total protein 7.4, albumin 4.2, globulin 3.2, AST 19, ALT 12, alpha 78, and GGT 33. Had a elevated amylase lipase report. Amylase level is 386, lipase 378. So other etiological workup, calcium 9.5, phosphorus 2.1, triglycerides level is 195, CRP on day 1 is 24, his HbA1c is 7.5, on admission his random blood sugar 285, plasma ketones were negative. So we did a echo, we saw global hypokinesia of LV and EF of 40%. So treatment given was we keep the patient in nil by mouth. I gave the IV fluids RL and DNS alternatively around 50 ml per hour after getting consulted with the cardiologist. We gave analgesic fentanyl infusion for the pain 3 ml per hour and taper down and stop within 3 days. Then we did a CT abdomen which showed, first image showed the diffuse enlarged mild features of mild interstitial pancreatitis, and second one showed mild, dilated CBD with hyperdense intraluminal calculus. The second image, coronal image showed the air in the left lobe of liver, pneumobilia, and second image axial section showed dilated CBD with hyperdense calculus with intraluminal air pockets in the CBD. In CT abdomen report, apart from pancreatitis, the professional report was mild IHBRD with mild minimal pneumobilia in the left lobe and dilated CBD with intraluminal air pockets and calculi with mild urinary bladder thickening. So after stopping Eliquis and Clopilot, we replaced with injection enoxaparin. Day 5, we did a ERCP and sphincterotomy done. So many stones and food-like materials is extracted after balloon trawling. This the ERCP showed a complete cutoff in the proximal CBD. We can see the arrow mark with intraluminal filling defect with the calculus. So is fitting with criteria for SUM syndrome. Some few points regarding SUM syndrome. This first generally discovered in 1976 before the era of ERCP. Is usually following bilioenteric anastomosis. Nowadays is very rare. The pathophysiology for developing SUM syndrome is where there is a excluded bile duct which had a reduced filling pressure and reduced peristalsis. So which had a so reflex of duodenal content to the CBD. Most of the patient had some sphincter of OD malfunction. So they tended to develop stones and more to develop cholangitis features. So most subsequent sequelae of this SUM syndrome could be a pancreatic biliary complication such as recurrent biliary colic, jaundice, CBD stone, cholangitis, liver abscess and pancreatitis. In our case, he presented with pancreatitis. The treatment usually ERCP biliary sphincterotomy is the 90% of treatment. In rare case, Roux-en-Y hepaticogenosmy will require. The take-home message, SUM syndrome is one of the rarest cause for the pancreaticobiliary complication. Still now we encounter the treatment could be a ERCP and biliary sphincterotomy is the treatment choice. We can consider in setting of acute pancreatitis, we can consider one of ERCP we can consider in the background of SUM syndrome other than acute cholangitis. Thank you. Yes, ma'am.
How do you correlate the clinical symptom with the elevated amylase and lipase? You think it's significant, 386 and 285?
Actually, first we think in terms of any DKA only, ma'am. So
yeah, that's what it looks more like a DKA.
So only we did plasma
so this
ketone.
may just be a bystander,
Yes.
just a red herring.
So
it is because that I would really not attach importance. It's not even 3 times elevated, no? If you take
Yes.
180, at
380.
least you no,
380.
if you take normal,
Yes,
80 to
ma'am.
180, at least you need a 540.
Yes.
So
Our reference lab value is 70, ma'am.
What the higher level is 70.
70.
70. So
70.
that's 210. But it's hardly,
Yes,
it's not even mild pancreatitis.
We have a diagnostic dilemma, so only we
Yeah,
did
it
a
is,
CT,
it
ma'am.
is. So what I'm saying is, it's just a bystander.
Yes,
and
ma'am.
this you can expect. You can even get Bezos there. You can get stones there. SUM
Yes.
syndrome we have seen.
Yes.
Usually they're asymptomatic unless you have a common channel for the bile duct and the pancreatic duct. Then you'll get a pancreatitis.
Yes.
Now, was it a common channel? Was it opening together?
No, ma'am.
Then how do you get pancreatitis?
I couldn't
No,
understand.
the CBD and pancreatic duct at the ampulla, they were opening together.
Yes, ma'am.
MRCP would have shown you a better information on the pancreatic duct.
Okay. MRCP we didn't.
I want to know because only when you have a common channel, you'll get a pancreatitis. But if they are opening separately,
They did a
these are-
hepaticogenosmy, so will be a distal CBD and pancreas will be a common channel only.
no. At the ampulla.
Yes,
at the
ma'am, ampulla level
At
only.
the ampulla, how do you know that it is a common channel? At the ampulla, the CBD may be opening along with the pancreatic duct as an ampulla.
Yes, ma'am.
So the variations are there.
Oh.
Supposing the bile duct was opening separately, then there's no chance of getting a pancreatitis.
Okay.
We don't have the anatomy, no?
Yes,
Of the bile duct and pancreatic duct, do you have the anatomy?
Yes.
MRCP,
We didn't
they've
do
not
no
done an
MRCP, only CT
MRCP
only.
is not done. MRCP would have given us that information.
Yes.
I think what is peculiar here is the OTPT levels are normal,
Yes, ma'am. Yes, sir.
absolutely normal.
Yes, sir. disconnected. The diagnostic criteria what they mentioned was the past history of some bilioenteric anastomosis with pneumobilia in the liver is more considered with some syndromes. Usually the some syndrome case report. Yes, I didn't. Yes. Yes. Yes, sir. So many. Some from duodenal into the negative pressure, they went into the CBDs.
But do you normally see food going into the
No, sir.
CBD?
No, sir.
In this case, probably they had an ERCP done.
At the time they did
done, and they opened up the
yes,
ampulla.
Yes,
probably that is the reason why.
They missed all reports, sir. Only one paper they showed all past history, sir.
But you can probably,
Yes.
postulate and say this is probably the reason. Earlier, previously.
Earlier they tried ERCP, sir. Then post procedure he developed biliary leak. They tried. Yes. Okay. Yes. Okay.
I think it is, as Madam suggested, before you take him for a therapeutic procedure, the ductal anatomy is very important. I think you should have done an MRCP, probably would have given you a better anatomical details.
Okay.
But I don't know about the house, whether they agree, because it is quite obvious that he had a dilated CBDs and all that.
Did
but
you do an abdominal ultrasound prior to CT?
No, sir.
Why is that? I know you're in a corporate hospital, but
Yes.
first imaging that you would do in a patient with pain abdomen would be an abdominal ultrasound.
When you did the ERCP,
Yes, sir.
when you did the ERCP, you were able to opacify the pancreatic duct also, incidentally?
No, not sir.
You cannulated selectively bile duct.
Yes, sir. Collective bile duct.
You are not able to visualize PD.
No, sir. The ERCP done by Dr. Ramakrishna sir. So he did directly CBD cannulation.
Yeah. In case some anatomy is shown there, I just want to check up with you.
He is not going into pancreatic duct.
Yeah. Okay. The ideal would be you do a MRCP before you do a therapeutic procedure. That too is a complicated case.
Okay.
You already underwent emergency cholecystectomy and then you had a leak. You went for hepaticojejunostomy. Anatomy is very important.
Okay,
It's
sir.
better.
Okay, sir.
And regularly ultrasound should be done in any case of acute abdomen. It's a very routine thing. Even before you see, the intensivist should have ordered and would have done it normally.
Next
Okay,
time we will.
thank
do,
you.
sir. Thank you, sir.
I invite Dr. B.S. Sneha from Miyot Hospital to have the review of Indian literature on Crohn's disease.
Good evening, professors and my dear colleagues. I'll be presenting the review of Indian literature on Crohn's disease. First, I'll be describing Crohn's disease in detail. American gastroenterologist Dr. Burrell Crohn discovered the disease in 1932. Before that, it was initially named as terminal ileitis. Later, the disease was named after Dr. Crohn. Crohn's disease is a chronic inflammatory disorder where the inflammation is often discontinuous and involves all the layers from mucosa to serosa. The etiology in a genetically susceptible individual, it's related to the immune dysregulation which is triggered by the intestinal microbiota, and it is also influenced by environmental exposure and dietary factors. Mainly IBD is increasing in India. One of the main reasons is westernization of the Indian diet and change of the dietary pattern. And there is also improvement in hygienic and environmental conditions. And of course, underlying genetic susceptible individual. So there is this hygiene hypothesis which states that children who are raised in relatively sterile environments are more prone to develop IBD in their life, because they are initially not exposed to the microorganisms, and later when they are exposed, they inappropriately attack all the organs. So studies show that people living in the rural areas or brought up in the farms or in large families who drink unpasteurized milk, they are likely to be protected against IBD. Both in Crohn's and ulcerative colitis, breastfeeding and tea or coffee consumption is known to be protective. In Caucasians, antibiotic use is considered a risk factor in both. Both in terminal ileum and colon, it has highest concentration of bacteria. That's why this region is more preferentially affected when the microbiota changes in our body. Coming to genetic studies of IBD, generally not two gene association is found in Crohn's disease, but in Indian studies it is shown that the autophagy related gene, IRGM gene, has an association with Crohn's disease. Symptoms of patients in Crohn's, generally patient presents with anorexia, loose stools, abdomen pain, weight loss, and compared to ulcerative colitis, tenesmus is less common, and even blood loss rectally is less common unless severe Crohn's colitis. And in 24% of patients, perianal disease such as fistula and strictures precedes the intestinal manifestations. And the disease behavior can be fistulizing disease or stricturing disease. And often after appendicectomy, when the patient is presumed to have appendicitis, after appendicectomy, patient develops intracutaneous fistula. That's how many presentations also occur. And 1/4 of Crohn's disease presents with an intra-abdominal abscess. Pathology, the hallmark is aphthous erosion, which is the earliest characteristic lesion. Aphthae, they represent the focal areas of immune activation. They generally arise over the lymphoid aggregates, sometimes barely visible to up to 3 mm and surrounded by halo of erythema. And the classical granulomas are non-caseating granulomas, in contrast to TB, which has caseating granulomas. Also linear or serpiginous ulcers are formed, and classic cobblestone appearance is seen. This is a picture of Crohn's where we are seeing cobblestone appearance, and in the second one, like fibrostenotic appearance of the mucosa. To classify Crohn's disease, it's classified by Montreal classification based on age, location, and behavior. A1, A2, A3, location ileocolonic, or if there is isolated upper disease, L4 is also used, and behavior, whether it is non-stricturing, non-penetrating, stricturing, penetrating, and P is if there is a perianal disease. And often this Crohn's disease activity index helps us to identify the disease activity. Less than 150 is in remission, more than 450 severe, and usually after starting response, if the severity index decreases by 100, it's a good response to therapy. Now coming to the review of literature in India, in IBD is increasingly reported from South Asia and Southeast Asia in the last 2 decades, and the studies have shown that in northern India, ulcerative colitis is more reported, whereas in southern India, Crohn's disease is more reported. And although ulcerative colitis is more common in all the 4 zones of India, the ratio of ulcerative to Crohn's was 8 times higher in north than south. And the mean age of diagnosis of IBD in India was 36.7 years. And unlike the West, there was no bimodal age distribution in our country. So there was no second peak seen at 60 to 79 years. Also, there was a male preponderance noted in India with a male to female ratio of 1.4 in ulcerative colitis and 1.3 in Crohn's. And the median age of diagnosis of Crohn's was 1 decade earlier than of ulcerative colitis, and majority patients were in the younger age group and 18 to 40 years. Nearly in the Indian studies, nearly half of the patient had onset of symptoms within 1 year, 1/3 had 1 to 5 years, and 14% was symptomatic for more than 5 years. And we know smoking was a risk factor for Crohn's. So in the study, around 5.9% of Crohn's patients were smokers. Highest percentage was seen in eastern and southern parts of India. Overall, the commonest disease location was ileocolonic L3, followed by ileal L1, followed by L2, which is colonic. And in 4/5 of the patients, B1 behavior, that is non-stricturing, non-penetrating, it was found in 79.9%. That was the most commonly seen. And 1/5 of the patients, that is 20%, developed extraintestinal manifestations, mostly from southern part of India, it was noted. Majority of these patients with extraintestinal manifestations, they were of age more than 40, having ileal disease, B1 behavior, that is non-stricturing, non-penetrating, and severe disease. There was a prevalence study conducted called ACCESS study, which was across Asia in 8 countries during 2011 to 2013. It stands for Asia Pacific Crohn's and Colitis Epidemiological Study. So this study was monitoring the environmental factors, and it showed that breastfeeding, more than 12 months, antibiotic use, and daily tea or coffee consumption were protective against both ulcerative and Crohn's. This table compares the Indian studies and the ACCESS studies. So in both breastfeeding, childhood pets, antibiotic use, there was no study in India, but in ACCESS study it shows protective, unlike in Caucasians where it is a risk factor. And toilet facilities, higher number of siblings, all this were more protective in a patient. Coming to clinical features, in a recent study published in Lancet in 2023, patients of Crohn's, 70% of them presented with abdominal pain, and 33% with altered bowel habits, 31% with chronic diarrhea, 19% with rectal bleeding, and 9% with anemia. And the earlier studies done in conducted in 2012 by ISG IBD task force, in that abdominal pain was 74.9% and weight loss was 66.1%, percentage of presenting with patients presenting with that. So majority presented with abdominal pain, weight loss, and next was even chronic diarrhea. Coming to colonoscopic features of Crohn's disease, in the studies in 2008, linear ulcers were commonly seen. Then in 2010 study, skip lesions and aphthous ulcers were commonly seen. In 2011, again linear ulcers, skip lesions, and aphthoid ulcers. The location wise, this is a graph showing the Indian studies and then ACCESS study in Asia and Australia. In that ileocolonic, that is L3, is the most common location found. L3 is the green, depicted by green color. And B1 type, which is non-stricturing, non-penetrating, is the most common behavior seen, which is seen in the blue color. Treatment, corticosteroid use was noted higher in the western and northern part of India, whereas immunosuppressants azathioprine use was used 53.9%. Patients were seen most commonly in the southern cohort, both that and biologicals. And a total of 10.14% patients underwent surgery for Crohn's disease. And the rates of surgical intervention, they were highest in western part of India. Often we face a diagnostic challenge between Crohn's and TB. So in that, gene expert test is highly specific for TB, although it has low sensitivity. And MAN2 and TB quantiferon gold are supportive evidence. And in radiologically, CT or MR enterography, lymph node size more than 1 centimeter on short axis favors TB. Often most patients, they would have undergone a trial of ATT therapy. So in these studies, 4.8% patients had past history of use of ATT, reported more from western cohort of India. Also, we can distinguish based on granulomas between TB and Crohn's disease. Non-caseating in Crohn's disease, and often they are multiple large and infrequent, small, and poorly organized in Crohn's, multiple large and caseating in TB. Coming to extraintestinal manifestations, like most common extraintestinal manifestation reported was peripheral arthropathy, which was seen in 33%, followed by ankylosing spondylitis in 18%, and ocular symptoms in 13%. The rest constituted around 9%, which is the mucocutaneous manifestation, aphthous stomatitis, and pyodoma gangrenosum. The frequency of extraintestinal manifestation correlated with the disease location in Crohn's, with colonic disease having the highest frequency. This was similar to the studies from the West. Family history of IBD. A positive family history was found to be very low frequency, similar to the much lower than in the West. In the West, there was higher family history. So here, 4.6% of them reported a definite diagnosis of IBD in at least one another family member. And similar to in India, other Asian countries like Sri Lanka, Japan, South Korea, and China also had seen a lower frequency of family history. Pregnancy and IBD have had a complex interaction. One affects the other. And similar to the West, there was more cases of cesarean deliveries and preterm births seen. And the disease course of IBD is worst when the pregnancy coincides with the disease onset, rather than it occurring before the pregnancy or after the pregnancy. And the outcomes were worse in Crohn's disease than ulcerative colitis pregnant patients. Pediatric IBD, the disease is more severe and penetrating, which requires the need for biologicals. And pediatric patients accounted for nearly 7% of new cases of IBD seen annually in India. The incidence of colorectal cancer in Crohn's, around annual incidence of 0.3% was seen, similar to the Western prevalence. And the probability of developing colorectal cancer in the first, second, and third decade was around 1.5, 7.2, and 23.6%, which was similar to a meta-analysis published by Aiden et al. Now, limitations of most of the Indian data was there were limited participation of centers in the eastern and western India, and missing data from few centers, and there was very poor follow-up of treatment of these patients. Summarizing the known things about Indian studies, this is taken from a review article by Dr. Mayank Jain and Dr. Jayanti ma'am. The known is there was no bimodal peak. Male predilection, low incidence of positive family history, tuberculosis, which complicates the diagnosis and treatment of Crohn's, so there's a diagnostic challenge. Extraintestinal manifestations, arthritis is common, whereas primary sclerosing cholangitis was rare, and milder disease severity and course. Unknown is the true population prevalence is unknown. Genetics also needs little more studies, and the interaction between the genetic and environment factor, impact on mortality and quality of life, and optimum management. Challenges is pediatric disease is increasing and extending into adulthood. Colorectal carcinoma is on the rise, and the cost of diagnosis and treatment is increasing, and patients' non-adherence to treatment. The articles which I have referred is from the Colitis and Crohn's Foundation of India, Nationwide Inflammatory Bowel Disease Registry, then IBD in Rural and Urban India, which was a 2023 article published in Lancet. Then Inflammatory Bowel Disease Indian Perspective Review article, Epidemiology of Inflammatory Bowel Disease in East, the Great Shift East. Then Indian Society of Gastroenterology, Consensus Statements of Crohn's Disease in India. These were the main articles I referred. And thank you. This year IBD theme is that IBD has no borders, and 19th May is celebrated as World IBD Day. Okay, thank you.
Excellent presentation, and you covered it in a short period of time. I think you can add, the cancer in IBD, which is non-luminal, non-GI.
Okay. Okay.
That's making a major, especially now we're having patients with 30 years and 40 years who are on azathioprine.
Okay.
So you have to highlight that one paragraph, and we also have the data on the radiological imaging in Crohn's disease. That's also in consensus paper from the Indian Society of Gastroenterology and
Okay.
the radiological group.
Okay, ma'am.
So I think those two publications can get added on.
Okay, ma'am.
And surveillance you mentioned, probably you can mention we have problems on surveillance in Crohn's disease. Ulcerative colitis is easy.
Easier, okay.
So add up these, because you'll be submitting this for the journal. So
Okay,
just
ma'am.
see that all these get added.
Sure, ma'am. I'll add on this. Thank you, ma'am.
Thank you for your lucid presentation.
Thank you.
Any points to be added? Okay. So before we conclude,
I think you can also add pediatric IBD is making a major impact. I think you need You definitely have to highlight that. No, they're having
Okay.
it's a huge challenge for them managing those group of patients.
Okay, ma'am.
I do not
Alright.
know whether they have limitation of words in the journal. Just check on that, and maybe you can take special situations, special considerations, and pediatric IVD needs elaboration.
Okay, ma'am. Alright. Thank you, ma'am.
Before we conclude, I would like to add a few points on the case presentations which were done for the interest of postgraduates. As we know, generally the right colonic lesions do not have any symptoms. Generally they present with anemia. Generally the left colonic lesions, they present early because of bleeding per rectum, and because the right colon is capacious, they may not have any symptoms, and the only presentation may be anemia. It is very unusual for a colonic malignancy to present in ascites per se. We can see such cases in gastric malignancy, say linitis plastica. Maybe this patient had more of an infiltrative malignancy like you mentioned, and the patient did not have any luminal symptoms according to the presenter. So this is little unusual presentation, but still it can happen. Like how in Crohn's disease, patients may not have any bowel symptoms and they may present only with abdominal pain when they have transmural involvement. This may be the case in this patient who had a Schirr's type of malignancy with malignant ascites. And the presenter, any female patient who presents with ascites, that to high protein ascites without pedal edema, we should also consider primary carcinomatosis, primary peritoneal carcinomatosis, or ovarian malignancy. So among tumor markers, you seem to have missed out serum CA125 and ascitic fluid CA125. That also should have been done. And this patient probably when she presented with abdominal pain, she has neglected the symptoms. Maybe a CT scan or even an ultrasound or some kind of imaging could have picked up this bowel thickening and could have prevented the consequences. This is my opinion about the first patient. Second patient, the etiology for biliary pancreatitis in patients with CBD stone is not very clearly known, and some say it is because of bile reflux when they have a common channel, or it may be due to per se the stone going and obstructing near the ampulla and causing compression over the pancreatic duct, and that can lead to intraductal pressure and pancreatitis. That is the exact reason why when we do CRE dilatation, when we keep the balloon for longer duration, the patients are prone for developing biliary pancreatitis. So it is also possible, I think, ma'am, without common channel, the patient can develop biliary pancreatitis if they have CBD stone. Correct. Edema and
any questions from the floor? Any comments? I wish to thank all the presenters for their wonderful presentations and all the participants from the floor as well. Thank you.
Thank all the chairpersons and the postgraduates for a wonderful presentation and a good interaction. We move on to the second part. Before we move to the CME, just have a short presentation from the Secretary's report. Good. So, last year in December, we had a ISG national meeting where most of us did participate in multi-fuel ways. And it's a honor for me, and it's a proud moment for all of us that ISG national body recognized our Tamil Nadu chapter as a best state chapter for the year 2023. And I think the kudos goes to all the members and all the office bearers who have done enormous work to get it forward, and all the stalwarts who are sitting here and who is taking this forward. These were the plaques that our patron Dr. K. Palaniswamy accepted the award on behalf of the society. There was a plaque which was given, also the certificate as well as a scroll. At this point of time, I would also want to dedicate this to our beloved patron, who I think would be very happy to have seen it if you were around, So I think it be dedicated to his loving memory. Moving on, we also had another proud moment where Dr. B.S. Krishna delivered the Dr. P.N. Chutani oration this year. And this year, I think we had a good representation from Tamil Nadu in various forums where I think my madam had delivered lecture, Dr. Seshadri had conducted a panel discussion and some more lectures, and where they were chairpersons. I think probably we should be doing, we should be able to get Tamil Nadu projected more in the years to come. And another proud moment was when in the India-US Summit in December 2023 at AAG, Dr. Vinod had got the second prize for the US video contest, and I think congratulations to him as well this year. So upcoming event, I think we're all geared up for our annual meeting. It's only 2 weeks away. The program is already out. I request all members to register. The abstracts and e-posters and endoscopic video submission is open. Still the 31st of Jan, I think the guidelines are already up. There is still a very low number of abstracts which have been submitted till now. It's only in about 10 or 11. I request all the postgraduates to make use of this opportunity to present. It will be a good forum for you to get the confidence to present, discuss with people. And there are exciting prizes also. The first top 2 posters, individual studies will also be awarded, will be judged and then awarded. And you also get selected to present in the plenary presentation as well. So please make use of this opportunity. I also request all the consultants and the heads of the department to make sure that their postgraduates submit their videos, submit their posters and interesting endoscopy videos before the 31st. And other important announcement that I would want to make is that ISDCon 2024 is happening at Varanasi, and Chennai will be beginning. Every year we have been trying to host this prestigious national body meeting. The ISDCon 2025, again we are bidding. The competitor will be from Punjab, Amritsar. So polling will be open from 4th to the 18th of February. All members who are national body members will be able to vote for the same. So please make use of this opportunity. I think we should try to vote ourselves and get our own colleagues and all our associates to help get this time, at least in ISDCon 2025 should happen in Chennai. So again, I request you to please scan and fill out the Google form, which will help us get the CME credit points from the TNMSC. Thank you very much, and I'll request Professor Jayanti to give a few words about the Women's and Gastroenterology Forum, please.
RPN to Secretary for giving me this opportunity. I'll not take much time, but if you see from the audience again, we are just about 10%. I'm wondering where the women folks are, There are 48 members, and only the professors are sitting. So I think it's time that the government starts, upgrading the women to become professors for them to attend conferences. That's what is happening. That's what is happening. So there are 48 of us, and we see 2 professors, and Hema always attends, and I also attend most of the conferences. All over Tamil Nadu, whatever it is. So I think one important thing that happened yesterday, if you all saw the Republic Day parade, 99% were women. Indian Navy, Armed Forces, AFMC, bikes, motorbikes, all the pageantry, everything was led by, it was women's empowerment. I don't blame the men for that. The women have to rise. That's it. And you're all lying low. You have to come to the front. You have to be, only when you participate, you will be visible. If you're not here, no one knows. I don't even know who are the other women in this Tamil Nadu chapter. So I've requested Dr. Revati and Dr. Preeti to take charge, okay? And I'm a little selfish in the sense that Malti and I, as senior people, are on the fading side. We are on the lower side. So I want a backup, okay? I want a backup. Malti and I, we decided we need a backup. So that today, in the National Forum, after 45, 50 years, the first time I presented in the ISG. So you can take, and that was because of Matthew Phillip. It was because Matthew Phillip was there, he considered people from South. So to rise to the expectations of the North, you have to do something, including the men folks. It's the first time I presented in 45, 50 years, and no point in sitting as chair or moderators. You have to be speakers. And to do that, you need publications, show your presence, you have to do it. You know, you don't have to have a high profile. Just do your work, see that your publications, attend conferences, attend meetings, meet people, sit in the front row and meet people. Once you start introducing yourself and talking to them, then you start becoming members of the core group. That's how we are in the core group. Otherwise, even South was not represented. NAFLD has no lady there, not lady, leave the lady, no one from South. NAFLD group has no one except I think one member from maybe Joy Varghese is there as a hepatologist. So I think it's time for the women folks, please do something. Each of you can pass on the messages to the people whom you know, including the postgraduates. And Preeti has not yet reached, so we have something in our mind, and I've requested them to give us a 15-minute slot in at the GB meeting in Madurai. So let us explore, and with the help of them, they have to help us, for us to rise. Okay? I've risen on my own. I didn't depend on the men folks to rise, okay? If it was that, I would never have risen. Dr. KRP, right? I rose on my own. I never bothered. I had like a vision of a horse hood, I would never bothered who the hell was around me. And that's the way it has to be done. And we're all here to encourage. We are here to encourage men. We are also here to encourage women. So I think this is my real humble plea, and I'm going to ask all the senior people to help us to achieve this. And mind you, this voice is not coming from me. It is coming from North, where people are saying, they've asked me to stand for governing council. I said, not at this age. They're saying, next year, ma'am, you become the president. I said, namaste, I don't want all that. Let the youngsters come forward. No, I've reached my fill, I'm just satisfied and I just want to enjoy myself. So I don't want posts. But some of you should come up and come forward, show your presence so that we elect you. Shobna Bhatia stood for election, but we're only 20%. She's anyway not going to get her votes. So we've requested for even a post of a president, at least once in 3 years, women should be there. No, we'll never get our votes because women is just 20% of the entire society. Okay? So, Jai Ho.
Thank you, ma'am. So we move up to the next session. It will be a CME. I request the chairpersons, Dr. Nirmala, Dr. Ubaldos, and Dr. Raja Yogesh to come over and conduct the proceedings. Dr. Nirmala, of course, is the chair and head of ICH Medical Gastroenterology Department. Dr. Ubaldos is a senior consultant gastroenterologist at Apollo, and Dr. Raja Yogesh is a senior consultant at MedIndia Hospitals. Over to them for that.
Good evening, teachers and friends. We have two interesting lectures waiting for us now. We know that now NASH is the leading cause for chronic liver disease in adults. We know that. And then I don't know if we will be able to treat NASH. But anyway, Dr. Eapen is here to tell us if we are really able to treat NASH.
Thank you, Dr. Nirmala, for the introduction. So it's we all know about fatty liver and NASH. The question is, would we be using medicines, drugs to treat NASH or not? So let me have a go at my take on it. So is fatty liver increasing in India? The answer will be, we all know, is yes. Why is it increasing in India? So this study, systematic review and meta-analysis by Shalimar from AIIMS, Delhi, came out 2 years ago. 50 studies were looked at. There are a total of 23,000 adults and 2,500 children. So almost 28,000 subjects were from the different studies we looked at. So in adults, the prevalence of NAFLD in average risk adult is 28%, and in high risk, for example, obesity, diabetes, etc., is 50%. This is NAFLD in India. And in children, the prevalence is 35%. So 1 in 3 adults or children in India have NAFLD. So using this data, I'm sure all of us are getting anxious patients coming and saying, you got fatty liver. So I reassure them. I tell them, you are Indian. Your passport is Indian. Oh, so, okay. So I'm telling them that it's very common in India now, and but we do not understand what makes the Indian to get fatty liver. That we do not understand. But I reassure them, you are Indian, or rather, it's a common problem in India now. I know it's a common problem world over, but that's the line I take now, and seems to reassure people. Okay, I'm an Indian. So why is it? Why is it that fatty liver is increasing in India? Now, is it true that it is only happening now and not there before? Or maybe the studies were not done before. But the sense is, no, it is only happening now. Now only it is happening more in India. So, some of the risk factors for progression of fatty liver disease can be genetic. We know some of the factors are genes like PNPLA3 and TM6SF2, etc. are risk factors there. Some are dietary factors and gut microbiota as well. So when you think it through, what is likely to increase in the last 2 decades or 3 decades? So it cannot be our genes remain the same. The Indian's gene is the same. I'm not sure whether the gut microbiota has changed or not. Maybe not. Maybe it does. They say diet can change the microbiota per se. So maybe it does. So it's homing on to, and I've added on physical activity, and so they say we are becoming more sedentary in our lifestyle. So when you think that through, I think it's coming to diet. So we are all getting more access to calorie-rich food. That is possibly the answer in the why the Indian is suddenly having 1 in 3 Indians are getting fatty liver. So then the answer probably is not really medicines, which is what Sir said. The answer is probably that we should have monthly meetings without the food. Or have a food which is more what it was like 20 years ago. The attendance may go down further. So I don't foresee it happening, but maybe that's probably what we need. Because that's possibly the reason why it's increasing more. So, should we be treating these disorders, which we know are lifestyle disorders, with lifestyle modifications or with medicines? So maybe I'll ask for some show of hands. I think fatty liver can't increase further, so go ahead. But I'll probably ask for a show of hands for where you stand on these. There are no right or wrongs with these. So, question is, would you opt for medicines or would you give lifestyle changes or both in patients with, I'll start one by one, let's say diabetes, only diabetes. Who are opt for, I'll start with both. Who are opt for both medicines? I think most people will say both, maybe. And only drugs doesn't sound correct. Only lifestyle changes doesn't look like that's happening either. What about dyslipidemia? Both? Yeah, I think most people are saying both. Hypertension? Both? Okay, majority is both still. What about obesity? Is it both? Is it lifestyle? Is it medicines? You know, medicines are coming, but as of now, so there's slight difference. So here we are saying it's all lifestyle. As of now, majority we are saying is lifestyle. So among ourselves, that's how I think we are approaching it. So with that, how would we look at fatty liver? If there's only simple steatosis, which is the commonest thing which we have. Now, I won't ask for show of hands, but I think we all will vary with what our takes on these are. But the international expert society say that one should not use medicines to treat fatty liver. They say the person who needs treatment is those who have NASH, which is a more aggressive form of the disease, and consider how we would treat people with cirrhosis. So, but 1 in 3 Indians have fatty liver. They do not have NASH as a problem, they have fatty liver as a problem. So again, the answer thereby is not, possibly not medicines, but we do not know. It's all a changing field, and how do we address this? with the, I think there's an epidemic of anxiety as well. Once somebody knows fatty liver, there are people running around, I got fatty liver, what shall I do, etc. So they say, not they say, Socrates said that food is medicine and medicine is food. So coming from the lifestyle angle, so I'm asking the question, can Indians lose weight? Is it possible? So it's possible, you have to be motivated, probably. And they say whether you can sustain the weight loss when somebody loses weight are all questions. But when I was thinking about that, it struck me that actually we all see the other side as well, like this. So this is, I was remembering a young chap from E Road who actually had hepatitis A, that's all he had. But he was very eccentric. But his problem was he lost 30 kilos of weight. And I asked him, what are you eating? See, for the last 3 months I'm drinking buttermilk morning, noon and night. So I told him, you can eat regular food. I remember he wept because he was not getting the food. So when he didn't get the food, he lost weight. And of course, he is not thinking from the obesity angle. He was not obese at all. He is tired and he has lost weight. Everyone is worried about him. Will he die of jaundice? All that. This is something we see all the time. In fact, because I am sitting only in hepatology, I see it almost every day. And I'm educating somebody, eat, man. You can eat. And I'm telling stories to make them eat. So it is true that when you cut off the supply, the weight comes down. That's the reality. So where did that hole come for him? So what I've noticed it is from the housewife or the mother. They are all worried the person will die of jaundice, severe jaundice. So they are trying, they know the formula. And the formula is different. Whatever the neighbors say is very different. Or the doctors say, or the family relatives say. But it's true that if you catch on diet, weight comes down. Now, this we all see all the time. But in fatty liver bar weight loss, it's not viewed like that. Here the mystery of jaundice, and people say, don't give, and one goes into one different types of restrictions of food. So I think this is very effective, surely, but one has to be motivated in the setting of fatty liver, should we do that or not? That's I guess the call. Now coming to the topic per se, then what about medicines to treat NASH? Should we be using that or not? The INASL consensus which came out last year homes in on 3 drugs. Now this is again a matter of opinion only. So the drugs they have picked up, this is Ajay Duseja's is the lead author here on this INASL consensus, which takes up vitamin E and pioglitazone. They are both from the PIVENST study, and saroglitazar, which is, as you know, a molecule made from India. So it's something to be very proud of, and it'd be nice if such molecules really blossom. It's good that it's something from India making to happen. So I'll go over each of these a little bit more in detail. So as you can see, these are all drugs aimed at insulin resistance, this metabolic syndrome which drives this phenomenon. So we know that these are all friends. Fatty liver, diabetes, dyslipidemia, obesity, hypertension, they all go together. So the treatments also are seemingly are drugs which are able to influence metabolic syndrome or insulin resistance. So vitamin E is primarily an antioxidant action. So liver inflammation, which is what the NASH is over regular simple steatosis, is what is targeted there. Pioglitazone, we know, is targeting insulin resistance. So it's an insulin sensitizer, and it comes under the thiazolidinedione group of drugs. And saroglitazar, I'll talk a bit more in detail in further slides. We are all aware it's a PPAR alpha gamma dual agonist. And there are a series of studies. In fact, there are almost 10 studies now, which have come out from on saroglitazar, and they are called, some of them are called evidences 1, evidences 2, 3, 4, etc. So where does it stand, and should we be using them? Now, studies have shown uniformly that the liver enzymes come down with these drugs. However, based on the registration trials which use these drugs, the suggested minimum duration is 2 years. So, does it make sense to use drugs like that? Or does it stop with 2 years, or should I continue it for lifelong? How long do we give anti-diabetic drugs, antihypertensives, or statins? Is it like that? It's an unknown right now. When we give it for longer duration, are there side effects which are not recognized as yet? So there are some side effects here which we should be aware of. Vitamin E, side effects mentioned are, one is prostate cancer and hemorrhagic stroke. So that's something to be aware of. And maybe in somebody who is a query of a prostate cancer, maybe I should not be using vitamin E. Something to keep in mind, to say. The trials, in the PREVENT trial, when they had serial liver biopsy done and compared with a placebo, there was reduction in steatosis, lobular inflammation, and ballooning of the hepatocytes, and the NAS score, the NAFLD activity score also had reduced significantly, but there was no effect on fibrosis. Fibrosis in the liver on histology is thought to reflect long-term outcomes, and it had no effect on body weight. So this being an RCT with a placebo arm, it is graded as level 1 of clinical of evidence. In this study, pioglitazone had similar histological findings, but there was no effect on fibrosis. This is in contrast to some other study where pioglitazone had an effect on retarding the progression of fibrosis. In fact, regression of fibrosis in one study by Guru et al. in UK, which is also an RCT. However, weight gain could be a problem with pioglitazone, as we are aware. So thereby, if already a person is obese, that sort of puts off the patient. And again, the suggested duration is 2 years. What about side effects of pioglitazone? Weight gain and heart failure is one of the side effects. And these are both with urological cancers. So there was some controversy around whether urinary bladder cancers were increased with pioglitazone. So what happened in I think it was the year 2013 or so, in India, the equivalent of US FDA in India is called the DCGI. So DCGI suddenly overnight took off pioglitazone from the market. So it is a valuable drug in the diabetic group, especially that time when the newer drugs were not there. So it became a problem that people couldn't access the drugs they were till now on. But why did they take it off? Because it was felt that bladder cancer, urinary bladder cancer was more in them. However, now different parts of the world, data sets analyzed, etc., felt that it was not higher than the control population. So then that label is taken off. And thereby it is felt that bladder cancer is not higher. However, in some of the drug pamphlets, it may still mention to look out for bladder cancer, though it is not, the jury, I think right now says it is not a higher risk. That's the thing about pioglitazone. When pioglitazone came in, before that, 2-3 other group of drugs in the same group, drugs came in and were removed from the market with severe side effects. One was stroglitazone, which had a problem with liver failure, and rosiglitazone, which had the increased incidence of myocardial infarction. Then only came pio. Why pio seems to be safe, and now it's more than 10 years in use in this group. Saroglitazar, in this evidences 2 trial, showed reduction in steatosis and the NAS score on serial biopsy, and no significant effect on body weight. But however, this is a level 3 evidence, and they say it's for a minimum of 1 year duration. Yet I think of the top 3 drugs, really it is vitamin E, pioglitazone, and metformin. Metformin also will come in here, though it doesn't come in the INASL list of drugs. Again, it's a drug, as you know, it's used for an anti-diabetic drug. So all the drugs that we have are targeting either glucose or lipid metabolism. So a bit more about saroglitazar. So these are targeting there's one organelle in the cell. There are nucleus, mitochondria, like that. One organelle is peroxisome. So proliferation of peroxisome, receptor activation of, so PPAR, that's what it stands for. And there are three main sort of isoforms or subtypes of these, not subtypes. They are PPAR alpha and beta or delta and gamma. So we are familiar with fenofibrate, which is primarily used to reduce triglycerides. So fenofibrate is a PPAR alpha agonist, while pioglitazone, which I showed in the previous slide, is a PPAR gamma agonist. So PPAR alpha agonist, which was fenofibrate, we use for reducing primarily triglycerides. So its an effect is mainly on the lipids, while the PPAR gamma, which is pioglitazone, is an anti-diabetic drug. So that's where that comes. Now saroglitazar combines these two. So dual agonist for PPAR alpha and gamma, but more of alpha action. And thereby it improves lipid metabolism, lipid profile, as well as improves insulin sensitivity. So theoretically it's very sound drug which can be used for NAFLD, and it has got multiple effects. It reduces uptakes of fats into the liver, it increases fatty acid oxidation, as well as reduces secretion of triglycerides. So this combination is what it made it to be good to be given for diabetic dyslipidemia. So you know that in type 2 diabetes, one type of lipid abnormality is raised level of triglycerides, raised level of LDL and low HDL. That combination is called diabetic dyslipidemia. And that is the first indication for which this drug was approved. Saroglitazar was approved because it seemed to fit nicely with that combination, is what comes. Now it also improves insulin sensitivity to a lesser effect, however, compared to this alpha effect. So this is one of the evidences trial which is conducted in USA, where it's a RCT, a phase 2 trial, and like a proof of concept to see whether what is shown in India can be shown in the West as well. That's how they said it. I guess it should, but that's what how they've written it up. They only have 16 patients here where they do serial liver biopsies after 24 weeks of treatment, and people are given either placebo, 2 mg of saro or 4 mg of saro, and they were randomized to placebo versus saro, and they looked at the histological changes of the NAS score, changes on serial histology, that is the NAFLD activity score. That was the primary endpoint. And they found that the primary endpoint was not significantly different, but the numbers were going in the correct direction. It seems to decrease the NAS score by using saroglitazar. There was marked improvement in hepatocyte ballooning and steatosis, and there was some resolution of steatohepatitis as well. Now, in patients with diabetic dyslipidemia, that means they were already meeting the indication for saroglitazar when they had fatty liver disease, is where the study from Dayanand Medical College used. So they took that approach. Here there was no liver biopsy, they only did fibroscan measurements and CAP measurements. CAP is controlled attenuation parameter on the fibroscan, that's specifically for steatosis. And we know that the LSM is for fibrosis in the liver. And looked at pre and post treatment after 6 months of saroglitazar. They found that again, everything seemed to go in the correct direction. The ALT levels, AST levels, and LSM measurements, that the liver fibrosis, are lesser when they use saroglitazar for 6 months. So they concluded that saroglitazar leads to significant improvement in liver enzymes, the liver fibrosis on LSM, liver steatosis on CAP measurements of fibroscan in patients with fatty liver disease and diabetic dyslipidemia. This is the evidences 4th trial where it's an RCT. Now, among the 9 different studies done, the 2 are preclinical models, again showing that there is improvement in liver enzymes, histology, in animal models of fatty liver disease using saroglitazar. And in this particular study of 106 patients who are randomized to placebo, saro 1, 2 and 4 mg for 4 months, and they looked at, here there was no liver biopsy. The parameters used were liver enzymes as well as the liver fat content by MRI scan. That's MRI proton density fat fraction, MRI PDFF. So they did that pre and post treatment. And they showed that the ALT levels come down, the fat content improves on MRI, PDFF, as well as insulin resistance, triglycerides all improve. And lipotoxic lipid species also improve. They measured some particular, the speciated the lipids. So the liver enzymes improve, and on MRI PDFF, after 6 months of saroglitazar, the reduction in liver fat is shown, as well as the lipid profile, which was what was seen in diabetic dyslipidemia. The biggest improvement is in the triglyceride levels. The cholesterol level comes down, HDL improves, LDL comes down. So it all goes in the correct direction which you would like. They showed that it was well tolerated. However, there has been some weight gain. It's more with pioglitazone, but it can also happen with saro. So they concluded that saro at 4 mg significantly improved liver enzymes on MRI liver fat, insulin resistance, as well as this dyslipidemia, which is atherogenic. So this is my last slide really. So the question really is, so these drugs are all showing promise. Should we be using them? Who should we use it for? And as I made the show of hands initially, for obesity we don't give drugs. For fatty liver, should we? So we are all hedging it a little bit. Should we or not? Recommendations say you should give it for NASH. Should we? Or should we focus on weight reduction? Like that's how where we are all at that point. It may all change soon, but that's where it stands now. The recommendations last year from INASL says that if we have liver biopsy, so they are focusing on liver biopsy, and biopsy shows NASH. So that means there should be fat plus inflammation. There does not need to be fibrosis. This is what the stance they've taken. So fibrosis with or without fibrosis. So in them, consider treating. So this is what it says. Now we know that most people who we're going to deal with fatty liver and raised liver enzyme will not have biopsy. So they have said if you have biopsy, then consider. If so, what drug to use? So they say it depends on age, diabetes, dyslipidemia. So it says what is in brackets is their assessment of the evidence. So if there is no diabetes in adults or in children, we can use vitamin E. So the difference is in the other two, it doesn't come in children. That's what they said. So in children is only vitamin E is what they've said. In adults, one can use pioglitazone or saroglitazar or vitamin E. The only difference here is, here they said only if there is no diabetes. If there is diabetes, it becomes pioglitazone or saroglitazar. So that's the stance they've taken there. While if no liver biopsy, then one uses fibroscan, for example, and in the non-cirrhotic person but with significant fibrosis, based on non-invasive tests like fibroscan, they say one can use these drugs. They say it's weak evidence. We know that in Bangladesh, obeticholic acid is used freely. We see a lot of patients using that there. INASL objects to it. They say do not. Again, it's a matter of opinion. They're using it. We are saying don't use it. It's all opinion. And in cirrhosis, they say no to drugs. And it's weak evidence. So I will stop there. So let me ask one or two, I'll tell you one or two situations where I've used. So commonly, I do not use these drugs. I am like this obesity only. I'm saying I would go for lifestyle modification. That's what I try to encourage. But I have used for a few patients where the family history is 2 or 3 relatives. First relative have died of fatty liver disease and cirrhosis or HCC. And now this person has got not only fatty liver, either NASH or NASH to cirrhosis. Then I'm thinking, the balance is changing in which direction. So the preferred drug which I have given for a few people has been pioglitazone. That's what I've used so far. But again, I am on the fence myself. I am not sure. Can I give pioglitazone long term? I don't mind, because I think it's been around as an anti-diabetic drug per se for more than 10 years. So it's okay. I am comfortable, I think, because the signals would have come out in literature by then. I am looking out for any chance of bladder cancer. I am not actively looking for it, but if there is anything like that in the history, I would not go there to say. So that's one example where I've been giving these drugs. So in a strong family history, I am inclined to give the drugs. But beyond that, I am myself on the fence, but this all may change. Cost is one factor as well. Vitamin E comes, I think, to 4 rupees per tablet. Pioglitazone is 10 rupees per tablet. Well, Saro right now is sitting at near 100 rupees. It's 90 rupees a tablet. It may change again. So if it change cost-wise a bit, maybe I may be more inclined to do it that way. But preparing for this talk, I realized that there is a lot of evidence with saroglitazar already. That's true only. There's no doubt about it. There are already now 9 studies, though only one has come out of the full paper. There's some problem with that. I'm not sure why most of the studies are not coming out of full papers, all sitting as abstracts. I'm not sure why that is so. But still, the data is accumulating, and that's good. And it's coming from India, why not? We should only support it. So I think I'll end there, and I imparted the confusion in the field, I hope. Thank you.
Dr. Eapen, I have one question. There would be some patients who have had this for 1 year. So now, do we have data what's happening to the fatty liver? Do they have a recurrence? What is happening after that 1 year? When do we expect, I'm sure Dr. Ajay Dusejan have been using it for the last 4 or 5 years.
Yeah.
So do we have some information now? After stopping the drug, are we reversing the process, or is there a recrudescence of the...
It's an absolutely valid question. I am not aware that way. I am aware of the opposite. That means there are now studies which say use of vitamin E for either 5 or 8 years and pioglitazone for 8 years, and that the benefit is sustained as well as there are no new side effects. But they did not do repeat biopsy. But not the ulta. I have not come across what you said. That means when I stopped the drug, it all went bad. But that focus is not coming. The researcher who invested in pioglitazone followed up to show that it is still working when we did that for 8 years like that. Other one I have not seen as yet. Chances are, unless they have lost weight or done something in that ground, it will reverse. We know that's what's going to happen. So that's where it stands. Yeah. But I have not looked out for that particular question, but I suspect that's what we'll get.
What would be your approach in treating a non-diabetic, non-obese NASH?
Lean NASH, yeah. So that's a nice question. Some studies in India, for example, Abhijit Chowdhury group in Calcutta show that 1/3 of patients are lean. So they are not normal body weight, they are underweight. So is it correct? Somebody looks a bit like Pirama, I think. So can we tell them lose weight further? Sounds cruel to do that. Can you tell them the exercise is reasonable? So should we give them drugs? So I do not know the answer. Okay? So that's a tough question. Let's say it's normal body weight, let's say, or overweight. Should you use same drugs? I'm not sure there either. So I said, when there is strong family history, I felt inclined. It's okay. I'm making the correct choice, I thought. I mean, and the patient is also happy. He's getting some drug on that. Other one, I did not know the answer, what to do. Do I treat? I don't treat usually.
Sir, my problem is when we use drugs like Pios and saroglitazar on these patients, aren't they more prone for their, they are all oral hypoglycemics in the first place. So aren't they more prone for side effects that way? Because they are non-diabetic in the first place.
Yeah. So I know in detail one study from Nottingham in UK by Guru Aital, where specifically used pioglitazone randomized control trial in non-diabetics. And they did not become hypoglycemic. They did not. So I wonder how it works in diabetes. Because, okay, but they did not become hypoglycemic. But it's only wise to tell people, please check your blood sugar occasionally if you feel giddy and all that. And if it is so, I would withdraw it. The few patients I've used it so far, which must be around 10 only, that did not happen. Only in one patient, however, there's been weight gain and some edema, but the person is happy to take because the circumstance in the family, I need some drug on, like that. So that person is willing to do that, and that's how I've taken that. That's what I Yeah, so steatosis, no fibrosis. Is it raised liver enzymes or normal liver enzymes? So normal liver enzymes, as of now, I am not giving drugs, which is what the 1/3 of India is. One in 3 Indians are, okay, to say. But if I have got raised liver enzymes, which is how much? The studies have used more than 50 is recruitment, 50. So that's a very borderline level only, okay. So should you treat? I don't know. So I am not been actively treating so far in that group. So when I am forced only, I am treating. That's what I have been doing. Not that I am right. Yes, I'm saying what I am doing. That's where I. So if somebody is on vitamin E, I am not taking it off. But I am not actively giving vitamin E either. I have not been doing that. So I have been trying to play around saying lifestyle, but I can sit on a high horse because I am sitting in Vellore. It's very different from the circumstances where each of us, where you're practicing in. So that's what I've been doing there. It doesn't mean I am right. That's what I've been doing.
So I have 2 questions. Suppose the patient is on vitamin E and the patient has a high risk of bladder cancer. So how do you monitor? Do you advise any monitoring?
Yeah, so vitamin E is prostate cancer, while pioglitazone is bladder cancer. One is we should be aware of it because otherwise we are setting up for litigation. Not only litigation, even otherwise a disservice. So remember, urological cancer is something we have to keep in our head always. So that's something I have to, in the background, I have to keep in my mind, as well as hemorrhagic stroke with vitamin E. So these two have to be in our head somewhere to say. Should we check anything more? Guidelines, actually I have not looked up the guidelines. I'm not sure should we screen for it or not. But just to be aware, and if there is a history in the family, let's say, then why should we go down that route?
So my second question is, a lot of patients with diabetes, with chronic liver disease, NASH, they come with a lot of anti-diabetic medicines. So where will I place saroglitazole in this group?
Yeah, so that's yet another question. That is, I am not up to date with the latest diabetic drugs. I can't even pronounce some of them. It's like that. So am I competent to prescribe them? But I think I'm telling in our own department, now we have more faculty on, somebody should focus on this area and become competent. Because right now we are not competent. So we are saying you go and meet endocrinologist or a physician, which is in a way is a bit of a disservice because he is now has to go somewhere else as well. But of course he or she should get the best of care. There's no doubt about it. So I think someone has to focus on that. It's needed because this epidemic is only increasing. Then we have to understand what are the latest drugs to use, which have its own side effects, indications, etc. And that's how to approach that. So currently, I am not taking that on myself because I feel I am not that competent. It again doesn't mean I am right. Just I'm saying what I am doing.
Liraglutide has come. Although we are not regularly conversant with the drugs and nuisance, we'll be doing the service if you don't use the anti-obesity drugs. Sure. Semaglutide has come in its daily form. Remember correctly.
Absolutely. I believe it's in Denmark, I think. Denmark is where the company which owns semaglutide is sitting. So they have suddenly become the highest share prices of the drug market in Europe. So, because the drugs are so effective. Now, should we be using that? If so, who should be using it? Is it endocrinologist? Or, that's the question how it's. So at CMC right now, it's with endocrinology. They make these calls, as of now. To say. Again, it's not saying it's right or wrong. That's how it's standing right now. Okay? Now, however, these drugs are very expensive now. So you start on the drugs, you lose weight because you will lose your money. So, but it may change. Very soon you may get drugs which are cheaper. The market force will play out. So it's a changing field. Right now, the show of hands initially said we all opt for lifestyle measure for obesity reduction rather than drugs. If you use these drugs, how long should we continue it? All those questions are going to come with that as well.
One small subset. Saraglitazar are available 2 names. I will not name the name. One for diabetologists, one for gastroenterologists, you know. So, lipocaline and bilepsa. So if such a kind of thing occurs, we should treat. There should be a diabetologist plus medical gastro combo should be there in every year, unless you treat this patient.
No.
I suppose.
I agree with you that. So what Venkat raises another point which I didn't bring up here. There are Saraglitazar was being marketed by the same company by 2 trade names. One is Lipaglyn and Bilepsa is by Zydus. However, what is put up here now is a new name because now the company which has now come in along with Zydus is one more company has come in. So that's how the new marketing has come. So just be aware that same drug, same molecule, same company is giving by 2 names. Now it was first approved for diabetic dyslipidemia because the lipid profile goes very correctly. What we've noticed about the raised triglyceride, raised LDL and low HDL, which with type 2 diabetes is called diabetic dyslipidemia, responds very well with Saraglitazar. Very, very well. Now, your question was about semaglutide. So I'm saying my stance is it's a bit like if I want to focus on it, and it's a good area to focus on because it's a large epidemic, then I focus on it alone and know all about semaglutide and then make my experience with it. Otherwise, I'm running a risk of like the newer diabetic drugs. I may not be up to speed of all the nuances, then I may slip up. So right now I'm leaving it to endocrinology. It may change. That's what I think.
Good evening, sir. That was a very thought-provoking discussion, sir. The doubt that I have is that if a patient, most of the patients would be already on drugs with statins. A few of the patients with fatty liver diabetics, they'll be already on pioglitazone. In case we decide to start them on Saraglitazar, will there be any interference with pioglitazone because already that is a PPAR gamma agonist? So would you stop the pioglitazone and then start, or you add on to it?
I do not know the answer, but these trials have not, it was a contraindication for exclusion criteria for drug entry into this trial if they were on these drugs. So they didn't take them on.
So in practice, we'll have to stop them on pioglitazone, or?
So the trials, they did not give them Saraglitazone. They did not give them Sara to overcome this problem.
Interference with statins, because that is again
statins they have used. They have
so
used
we can
that.
combine Saraglitazar with statins.
That they have used.
Thank you, sir.
Excuse. Sir, we know in patient who are not undergoing biopsy, which we want to treat the patient who is having raised liver enzymes, we are not doing biopsy. Suppose we want to start the medications, either pio or Saraglitazar. We know the statins also can produce a derangement in LFT. How we are sure whether it is due to NASH or it is due to statin-induced or DILI or whatever you call it as? How to make a decision whether this should be considered as a NASH or it is statin-induced?
That's good. So I'm sure all of us have faced this. And see, somebody's got liver enzyme 50, big deal. 150, then we start to think of it. And this person needs one more drug. Or let us say, we may have a situation where somebody needs cancer chemotherapy. So let's say breast cancer. And we know 1 in 3 has got fatty liver. And now the liver enzyme is 150. And I'm also on statin. So then I cannot take a sit back. Now I have to intervene more there. So it's easy to give drugs which reduce liver enzymes. We know all these drugs are doing that. Then I like vitamin E. I know it's likely to affect and likely to have an effect. It will bring it down. 2 is, can I come off the statin? Will I cause immediate harm if I come off statin? It's unlikely. I don't think, unless somebody got severe coronary artery disease, it's okay to come off statin. So that person who needs chemotherapy for breast cancer, which also may start irritating the liver enzyme a little bit, who knows. So I would like to quickly bring down the liver enzyme. So I would consider taking out the statin in that patient. I would consider adding on vitamin E, and then liver enzyme come down a bit. so that early I can get on to cancer chemotherapy. That's something which I must say I have encountered a fair bit. All of us may have. When there's no pressing need like that, then I am a little more relaxed. Okay, so with an enzyme of 50, I am not thinking much about it. Enzyme of 150, I would intervene. I would do something, but I would analyze it exactly what the point that you raised as well. I would consider, can I stop the statin for some time, maybe give vitamin E, and then from there take the next step. So there are a whole list of newer, like anti-diabetic drugs, lipid-lowering drugs, and NA failure drugs as well. So it's dead easy. So when a student discusses with me about could the drug be causing it, answer is in MBBS in pharmacology, side effect. If you say nausea, vomiting, diarrhea, jaundice, you are pass, because any drug can cause jaundice. So that's why the student is passing. Students should know, I should say jaundice as well. So I would approach it, any drug can cause. But some drugs are more potentially hepatotoxic, that is true. But reality is any drug can cause it. So I have to use that principle to approach it. That's beyond that.
Actually, we are running short of time. Can we finish it? Thank you so much for your thought-provoking lecture. Defecated disorders, I know they are becoming more and more common and also coming into light now. So one of the investigation method is defecography, and most of us don't have much idea about it. So we have a lecture on defecography in clinical practice by Dr. Anu Eapen, the Professor Department of Radiology, CMC Vellore. Over to Dr. Anu, your wife. Incidentally, she happens to be wife of Dr. Eapen. He wanted me to mention this, that's why I mentioned.
Thank you, ma'am, for the introduction. So I'll be speaking on defecography studies in clinical practice. So we'll start with the conventional imaging, which is the fluoroscopic defecography, also known as evacuation proctography. So this is a simple, well-established test to evaluate the defecatory process, and it is the best imaging modality to evaluate a patient with obstructed defecation. So some preparation prior to a fluoroscopic defecography, patient is given a cleansing enema, bladder is emptied, it has to void. So patient lies left lateral decubitus, catheter tip is placed in the rectum, contrast is instilled, and the contrast that we use is a barium paste, 120 to 240 cc, which is should have the consistency of stool, and till there is an urge to defecate. And vaginal opacification also with contrast can be done. Now, patient, after the contrast has been instilled, patient is positioned on a portable commode, left or right lateral position, and some films are taken, spot films at rest. And prior to starting all this, patient should be given instructions to perform squeeze, strain, and on instruction to perform the act of defecation. So during each of these maneuvers, spot films are taken, and then a post-evacuation film is taken with maximum strain. So these are some spot films taken during a fluoroscopic defecography. This is a patient sits, it's a lateral view of the filled rectum, and spot films taken while at rest and while he performs these maneuvers, squeeze, strain, and defecate. So some things that we look out for on fluoroscopic defecography, one is the anorectal angle. So this is the angle shown by it's marked out in red there, angle between the posterior wall of the distal rectum and the central axis of the anal canal. So this would be the axis of the rectum, and this is the anal canal. So this is the axis of the anal canal. So this is the anorectal angle. So as you can see, during straining and defecation, the anorectal angle tends to become wider or more obtuse, and it's maximum during the defecatory phase. So at rest, the anal canal is closed, and the anorectal angle measurement would be around 70 to 140. Now while he performs the squeeze maneuver, the anal canal shortens and the anorectal angle decreases. And then during the performance of strain, as he's straining, the anorectal angle goes back to its resting state, and with when he's asked to perform defecation, the anorectal angle increases. As you can see here, it's become quite obtuse when you compare it with the resting state, and the anal canal opens and the patient can evacuate the barium. So anismus or pelvic floor dyssynergia. So these are some of the things that you see on the defecograph. So at rest, you can see if you look at the anorectal angle at rest, strain and defecate, there's no change. So this happens when there's failure of the puborectalis and external anal sphincter to relax. The anorectal angle remains acute, and during the performance of strain and defecation, it doesn't widen and it doesn't become more obtuse. So this was another patient with anismus or pelvic floor dyssynergia. You can see again there's a prolonged and incomplete rectal evacuation, and the anal canal remains closed. So here again you can see this is the anorectal angle that has remained the same. It has not become more obtuse, and the anal canal remains closed. So the descending perineum syndrome is the descent of pelvic floor due to chronic straining. So we need to have a reference line to evaluate how much has the pelvic floor gone below. So what we use is the pubococcygeal line from the inferior border of the pubic symphysis to the last coccygeal joint. So this black line represents the pubococcygeal line, and so descent of any organ is with respect to the pubococcygeal line, how much has it gone down, and that will help to grade is it mild, moderate or severe. So the descending again, abnormal caudal movement of the anorectal junction, which is marked here with a red arrow. So this is the axis of rectum and this is the axis of the anal canal, and this red arrow here is the anorectal junction. So how much has it gone below the pubococcygeal line? So that tells you how much the pelvic floor has gone below. Now rectocele is usually the commonest that we see is an anterior rectocele. It is an outpouching anteriorly of the rectum. So it is it's a protrusion beyond the anterior wall of the anal canal. So here, so this is the anal canal. So this is a line drawn through the anterior margin of the anal canal and then extended upwards. So this, how much has the anterior wall of the rectum bulged beyond that line? That is the measurement of the rectocele. So this is an anterior rectocele. The small rectocele would be less than 2 cm, medium is 2 to 4, and the large is a rectocele which is larger than 4 cm. So again, these are some patients with rectocele. So you can see a small rectocele, a little bigger rectocele, and a little larger rectocele. So it's all with respect to the line drawn along the anterior wall of the anal canal. Now, rectal intussusception and rectal prolapse. So what you mean by rectal intussusception is an infolding of the wall of the rectum. So it can start with a very mild infolding of the rectal mucosa. Later, when it's more severe, it can be a full thickness wall invagination. And if it's large enough, it can extend down into the anal canal. Then it becomes an intraanal intussusception, and then finally it becomes a full thickness prolapse. So on these images you can see it starts off as a small infolding of the rectal wall. Here you see a little bigger infolding, and that mucosa wall which has gone in is seen as a filling defect in this contrast filled rectum. And this is a large, the infolded rectal wall has come down into the anal canal and it's protruding out. So this was a full thickness rectal prolapse. So again, some more images. So this is the thing what we saw earlier, and you can see that the lumen of the anal canal lumen has become quite narrowed because this has caused an obstructed defecation with retention of contrast, and this is the mucosal folds protruding out at the anal verge, and this was again a frank prolapse. So rectal intussusception can be intrarectal. Then as it further progresses, it becomes intraanal and followed by a complete prolapse. So now few other things that we can see on the difficogram. Abnormal descent of peritoneal contents into the posterior cul-de-sac. So you can have a peritoniocele, enterocele, and sigmoidocele. So here, this was a patient with sigmoidocele. So what we again here we to say there is sigmoidocele, we again draw the pubococcygeal line. How much has the sigmoid colon gone below the pubococcygeal line? So you can see on these early pictures, the sigmoid colon is quite high up. But with further straining and defecation, you can see that this has come quite below. And if you had to draw the pubococcygeal line, this would be way below the, so this is a sigmoidocele. Similarly, enterocele again refers to descent of small bowel. Again, the landmark below the pubococcygeal line. So this was a patient, you can see loops of ileum. So initially it is here, then it is here, and then it has gone way down. So this was enterocele. So less than 3 centimeters mild, 3 to 6 centimeter moderate, and more than 6 centimeter below the pubococcygeal line is a large enterocele. Now moving on to the MR difficography. This gives the advantage of MR over fluoroscopic difficography is that you can evaluate all the 3 pelvic compartments, and also it is does not involve radiation. So you can use a closed magnet. Closed magnet is the usual magnets, which is what is recommended. A patient lies supine with a phased array coil around the pelvis, and this is the preferred technique because it provides a better resolution. The open magnet patient actually sits, it's more physiological, but the lower signal to noise ratio and therefore a lower resolution. So just because we spoke of pelvic compartments, your pelvic cavity, we can divide them into 3 compartments. Anterior, the bladder, urethra, middle compartment, uterus and vagina, and posterior, the rectum and anal canal. So again, difficography techniques, bowel preparation the night before study is optional. Voiding half an hour prior to study. It's good to have a little bit of urine in the bladder to help detect things like cystocele or anterior vaginal prolapse. So this is a sagittal section through the pelvis during a difficogram. So this is a partially distended bladder. This was a male patient, so you're not seeing the uterus in between. And this is a rectum which is well distended. Now, patient is again, like we do for the fluoroscopic difficography, patient is given instructions about the rest, squeeze, strain, and defecate phases. And to avoid excess movement or lifting of the pelvis, to avoid movement-related artifacts on the MRI. Now, rectum is again filled with 150 to 180 ml of ultrasound gel. Vaginal gel is optional, and the patient is made to wear an adult diaper or an absorbent towel placed on the gantry to avoid soiling. Now this is just the difficography protocol. I'll just skip this. So again, there are several lines used for staging pelvic organ prolapse on MR. The pubococcygeal line, which we have mentioned during the barium fluoroscopic difficogram, this has the highest reliability of all MRI measurements. So it is, as I said before, you can see the landmark. So this is the pubic symphysis. So the inferior margin of the pubic symphysis to the last coccygeal joint. So you can see it a little better here than on the barium difficogram. So pubococcygeal line is the most common reference line that is used. So organ prolapse is, as I said before, a reference point in any organ, whether it is in the organ in the anterior compartment, the bladder, the uterus, or the rectum. There are specific reference points, and how much have these gone below the pubococcygeal line, then this is measured at rest and defecation. So reference points in the anterior compartment, it is a posterior and most inferior part of the bladder base. So this is a bladder, and this is the reference point of the urinary bladder. So here, this is way above the pubococcygeal line, so there's no cystocele. In the uterus, the reference point is the anterior and inferior part margin of the cervix. And if he's had a hysterectomy, then posterior superior vaginal apex. And in the posterior compartment, it is the anterior aspect of the anorectal junction. So this is the rectum, and this is the anal canal. So this would be somewhere here is the anorectal junction. So the anterior wall of the anorectal junction. So that would be the reference point. So in this patient, it has just moved a very little below the pubococcygeal line, which is within normal limits. So the rule of 3 is what we use to indicate the severity of organ prolapse. Mild when the descent is just 1 to 3 centimeter below the pubococcygeal line. 3 to 6 is moderate, and more than 6 is a severe prolapse, whether it is bladder or uterus or rectum. Now there are 2 other lines which I didn't mention on the fluoroscopic defecography, but we can probably better make it out on the MR, because the bony landmarks etc. are a little better visualized. So H line, so we have talked about the pubococcygeal line. H line is the distance from the inferior border of the pubic symphysis to the posterior wall of the rectum at the level of the anorectal junction. So this is the pubic symphysis, this is the rectum, and this is the anal canal. So anorectal junction, the posterior wall. So this is the H line. Now what does the H line indicate? It indicates the width of the pelvic hiatus. So a diameter more than 5 centimeter is abnormal. That means it's an abnormally widened pelvic hiatus, and therefore the patient is more likely to have organ prolapse. So here these are 2 examples. This was a normal H line, and you can see in this patient H line widened. This is about 7.9 centimeters. So this is a widened pelvic hiatus. Now there's one more line, the M line. So we have seen the pubococcygeal line and we have seen the H line. So when you drop a perpendicular from this to the, when you connect up the 2 lines, that is the M line. So what does that indicate? This is the degree of measurement of pelvic floor descent. So any length of the M line more than 2 centimeters is abnormal. That means we say that there is abnormal pelvic floor descent. So you can see again examples. This is a normal M line, and you can see the M line here is 5.3 centimeters. So there is pelvic floor descent. Now, so this is just a table which shows how the normal and abnormal values for H line and M line. Now, peritoniocele, we saw the enterocele and sigmoidocele on fluoroscopic defecogram. So peritoneal cele is the pelvic peritoneal sac herniates into the rectovaginal space below the proximal 1/3 of the vagina. So here on this defecography, this is the fluid-filled rectum, and this is the bladder, and this would be the vagina. And this space, this is a cul-de-sac. So herniation of the peritoneum right and quite low down, that is a peritoniocele. Similarly, we can have enterocele, sigmoidocele, and all these can compress the rectum and cause obstructed defecation. So again, I'm just repeating some of the things that we saw on the fluoroscopic defecogram. Rectocele, like I mentioned before, it is the protrusion of the anterior rectal wall beyond the anterior wall of the anal canal. So this measurement marked in red is the measurement of the anterior rectocele. So a lot of it is repetitive. Then the descending perineum syndrome, also known as pelvic floor relaxation. So this results from loss of the pelvic floor muscle tone, and this leads on to descent of pelvic floor. So here in this patient, you can see that there is both the lines are abnormally widened. A widened H line, which means that there is widening of the pelvic hiatus, and M line widening means that there is severe pelvic floor descent based on the measurement. Something else to look for in descending perineum syndrome is the levator plate. So what is the levator plate? It is a part of the iliococcygeus muscle, which actually, this is the muscle. So it goes posteriorly to insert on the coccyx. So the levator plate normally is parallel to the pubococcygeal line. You can see in this patient it's almost parallel. But when there's a caudal widening, like the caudal inclination of the levator plate to more than 10 degrees from the pubococcygeal line, it's not parallel anymore here. So then that indicates abnormal pelvic floor relaxation. So again, rectal interception. So it's like I said before, invagination of the rectal wall, and rectal prolapse refers to a full thickness invagination of the rectal wall with eversion of the rectum, which is what we see here. So it has fully come through the anal canal and it's protruding at the anal verge, and this can lead on to obstructed defecation. Now just show you one or two conditions of the anterior and middle compartments, just to know that, show that MR defecography can be used for, for all areas of the pelvic cavity. So cystocele is again an abnormal descent of the bladder neck more than 1 centimeter below the pubococcygeal line. So this is a urinary bladder, and you can see that the reference point is way below the pubococcygeal line. So this patient had a cystocele. Again, the rule of 3 is used for grading the cystocele, and cystocele again can bulge into the anterior vagina. Middle compartment, uterine prolapse results from weak supports. These are all the supporting structures of the uterus. So you can see that here the reference point, which is here, has gone way below the pubococcygeal line. So this was a patient with a uterine prolapse. Again, the rule of 3 is used for grading, and usually when there's organ prolapse, there'll be the H line, M line, all these will be abnormally widened. So there have been many studies comparing the two, MR defecography and fluoroscopic defecography, and these have shown that while MR defecography probably is more comfort-wise better for the patient and less embarrassing, for evaluation of the posterior compartment and obstructed defecation, fluoroscopic defecography is better. And the advantages of MR: lack of ionizing radiation and multi-compartmental information, especially if patient is symptomatic for all 3 compartments. So, thank you.
Thank you, madam, for the excellent talk. How long will you take for a defecography, generally?
The fluoroscopic defecogram, maybe about half an hour.
Generally, I recently underwent an MRI of my neck. So the process itself was around 20 minutes. And what they apparently told me was that there will be movement artifacts if I keep moving. But this defecation, obviously, it is a very dynamic process. So how come the MRI is able to capture during the process? Is there any movement artifact? How does it get eliminated?
So,
technical doubt, of course.
So we use specific sequences which are used for these rapid, fast-moving things, used for cardiac imaging, MR enterography, for bowel. They are known as the true-phi sequences. So for the cine part of it, like the dynamic part of the study, we use those specific sequences, and therefore you don't get artifacts.
Is it feasible in children also, madam? Your experience?
The indication for defecography is not that common in children, but we use MR enterography we do for children, and you can use the same sequences.
Open for discussion.
Madam, it's going to open and close magnet. This is used mainly for claustrophobic, isn't it?
But the resolution with open magnet is very less. So what is recommended is the regular closed magnet.
What is, I should ask this question, what is normal charges for fluoroscopic defecography? Dental or approximate cost?
I'm sorry, I can't remember offhand the CMC charges. It will definitely be more than 1,000, I think, but I'm not.
1,000 is worthwhile, madam. It's a difficult problem. So 1,000 is high. More than 10,000.
No, it's not of that range. You know.
Generally, during squeeze, ma'am, what happens to the puborectalis? I expected the anorectal angle to become more acute because of the puborectalis contraction. But in your slides, I saw that the anorectal angle actually becomes straighter during squeeze.
squeeze, either it may, it's supposed to become smaller. The
It
angle
should be more acute.
More acute.
Yes, ma'am.
But when you keep doing difficograms, all these textbook things don't always, when you actually measure, and you'll find that it doesn't always follow what is described in textbook. It tends to vary a little for every patient.
Thank you, madam.
Good evening. So, first we had the problems of the oral side because of increased intake. Now we'll have discussion about the problems about the aboral side. So, defecatory disorders. I think Madam has given a very good view about the radiographic studies of defecatory disorders. We'll have a few case discussions on this. So, I invite the rest of the panelists. Dr. Preeti, consultant gastroenterologist from Apollo Hospital. Dr. Shankar, professor in HOD, surgical gastroenterologist from from Ramchandra. Dr. Raja Maheshwari, she's a professor of urogynecology, and she's been instrumental in establishing urogynecology in India, and she's heads the department in Curie, and she's got a lot of accolades to her side. And Ms. Aditi Nair, she is a physiotherapist from P3 Wellness. She's done her physiotherapy from Manipal. So I think what I prepared, I will rush through a few slides because as we run a little short of time. So, but we will try to make it a little interesting. So this is a list of the panelists we have. I think I've woken up some of them behind. Okay, so the next 60 minutes it was supposed to be, but I think it will make it 45 minutes. We'll have some discussion on the overview of the defecatory disorders. I'll give a brief idea in the beginning. I'll make it a little shorter. We'll have some 4 case scenarios and a pediatric case scenario. There are some surprises and breaks also. So these are some basics. I think all of you should know. Anal sphincter and continence mechanism. The most important is the sphincters, the internal external anal sphincter, the puborectalis sling, which maintains the continence, and the anus, which is responsible for the sensation of the various contents which come into it. So the continence for us is more for solid, then liquid, then gas. That's why the first incontinence comes for gas. So defecation physiology, first there's a rectal distension, then there's what is called a sampling, then there's a rectoanal inhibitory reflex, and there's relaxation of sphincter. Whenever the situation is appropriate, we defecate. So what is sampling reflex? I think someone from behind should answer. The mic can go around. 30 seconds for the answer, otherwise we go ahead. Behind. So this is going to be a different panel discussion. No? We'll start from there, and then we'll come to the panelist here. Yeah, the one person there. You have to answer, otherwise we'll waste time, therefore you won't get food after that. Sampling reflex, no one knows. Okay, sampling reflex is very important. This is how the anal canal senses that what is coming into the anal canal is either liquid, solid, or gas. So if it is gas, we are able to expel it without soiling our dress. So in one of the CMEs before, one of the surgeons said, anal canal is one of the most intelligent organs in the body because it is able to, such a small area, it's able to process too many things. And it has also got cavernous tissue. That makes it more interesting. So if someone scolds you with the word anal canal, you can compliment them for that. So it's important to know the anorectal physiology. I'll just briefly stop here. Pudendal nerve is very important, and the pudendal neuropathy is because of trauma and also diabetes are one of the reasons for the defecatory issues. So we have a spectrum of defecatory disorders. We have dyssynergic defecation, pelvic floor disorders. Then you have rectocele and rectal prolapse, which are more related to the organs, and associated disturbances we have. And the common symptoms are prolonged straining at stools, long duration at toilet, incomplete evacuation, bleed PR because of either hemorrhoids or SRUS, digital evacuation of stools. That's one thing which you have to always ask, and use of perineal supports. Most important thing is always colonoscopy is important to rule out any obstructive lesions before we go for other tests. At our disposal, we have anorectal manometry and difficography, which the radiologists have already talked about. So symptoms of fecal incontinence, overt symptoms all of us know, but it's very important to know about the covert symptoms, which we have to elicit from the patient: postprandial rush to the toilet and flatus incontinence. That's the first thing which comes. Symptoms worsening with loose stools and urinary incontinence. And of course, these are the various risk factors which we have to think about. The last two things which I mentioned is MSM and sexual abuse, something which is not looked into many times, but when other causes are excluded, we have to think about that. So generally in anorectal manometry, these are the various things we look into for fecal continence, and we study the sphincter, we study the defecatory pattern, and study the neural arc integrity. So the election season is coming up. So we know that the index finger is powerful. So the art of rectal examination, which is something which is lost, I think that it gives a lot of information. So before we ask Dr. Preeti and Dr. Shankar to give their comments on that, I need someone from this table to tell what they are going to get from a simple rectal examination. 30 seconds, black shirt or red shirt, someone.
First, I will tell the patient what I am going to do. Rectal examination. I put the patient on left lateral position. First, I inspect the perineal area, whether it's skin tag, fissure, and any abscesses and fistulous tract. Then,
right.
Yes, sir.
Yeah, go ahead. Faster.
I inject gloved fingers to the introduced in the anal canal.
Yeah.
So first I will see external anal sphincter tone, whether it's lax or not. Then I will ask the patient to squeeze, whether its contraction is going up or not. Then I inform the patient to ask to as like passing motion, whether it's the sphincter external sphincter is relaxing or not through this lowest portion. If it is again contraction, which indicate fecal evacuatory dysynergia.
Fantastic. Extra plate biryani for him today. So Dr. Preeti and Dr. Shankar, anything you want to add on that? Any other information you look for in Mike here, please.
Coming to the digital rectal examination, this is the only clinical examination which depends upon the physical attribute of the clinician. It depends upon the length of your finger. Okay. Probably a Marfan syndrome patient can palpate a higher rectal cancer. Okay. No other clinical examination depends upon the physical attribute of the clinician. Having said that, rectal examination should be a very gentle process. It should be a gentle process. You make the patient comfortable, and the prerequisite for a good rectal examination is an adequate history, because without a proper history, you do not know what you are going to find out. Say, for example, patient comes with an obstructed defecation. The commonest cause of though they said a lot of things, commonest cause of obstructed defecation is piles. So if you, for that you have to, it's not sufficient that you do a rectal examination, you have to do a proctoscopy. And suppose that the patient has skin continence, you have to examine the squeeze pressure, resting tone, everything. And that's the best time to teach the patient regarding sphincter strengthening exercise. When you are doing a rectal examination, you can teach the patient sphincter strengthening exercise. And and in females, you'll have to always do a vaginal examination, examine the perineal body. So all these things will complete the examination.
So the complete perineal examination is important. Preeti?
Absolutely agree with what sir says. One thing is, please afford privacy to your patient when you're doing a rectal exam. Not with a phone in the crook of your neck and a rectal exam, or talking to someone else, because all this happens in daily practice. It is a private and, as sir says, a gentle exam. Please tell the patient, I'm going to insert my finger, not just shove it in. And as sir said, half of your patients with dyssynergy can be diagnosed with a simple rectal exam. When you ask them to strain, you will not be able to pull your finger out. And you can always be sure that your anorectal manometry is going to corroborate with the same. It just takes 3 minutes. And in women, look out, you might see a procedentia, you might see a vaginal or a UV prolapse. If you use your 3 minutes well and give patient adequate privacy, you will more or less to the times find out what the diagnosis. You don't need to really go further in most cases.
Exactly. So that gives a clue to the diagnosis. It may not give you the diagnosis, at least you know the direction. I think that's the most important. Privacy and explain to the patient. It's a gentle examination. So I won't go into the details of this. So when the values are beyond, it's going to be abnormal. That I think we'll discuss as we go on. So when would you not do a rectal exam, anorectal manometry? Anorectal manometry is important for diagnosis of certain conditions. When will you not do an anorectal manometry? I think the last middle table, some postgraduate there. Blue shirt with a mask. You can take the mask and answer. Fast, we'll run out short of time. When will you not do an anorectal manometry?
Without consent, sir.
Right. I got the answers. So whenever any obstructive lesion is suspected, you don't do it. In an acute anal fissure, you don't do because it's going to have a false then there are strictures, anorectal malignancies, you don't do. When there's active proctitis, you don't do. Of course, when you don't have consent, you don't do. So these are we have commonly we have water perfusion and solid state systems. The one which is in the right extreme is the one which most of us have, the water perfusion system. The one which is in the middle is the one which is now coming into vogue. They have a motorized system which pushes the water through all the channels. And the one at this end is the solid channel, which is expensive. It's almost like a Benz car. Not all of us can have. So the preparation is done in the morning and water is filled up in the jar and that pushes all the water through the channels and the perfusion is done through that. I think I'll cut short this because of this lack of time. So this is the catheter without the balloon. We have the catheter, it's a 16 channel catheter through which the water perfuses and we have a balloon at the tip for sensations. So most important is be sure there's enough water in the jar which perfuses the water through the system. Because if there is no enough water, we'll run into trouble because it will not give a correct diagnosis. You will have blue color and all the different colors will be there. So I think you should be very sure so that you don't run into problems. Right, so the procedure as such is, again I'll go through very quickly. So first you get the patient comfortable, left lateral position, the catheter is inserted after explaining to the patient. Then first we have what we have is the basal pressures. This is the basal pressure measurement. So once we finish the basal pressure measurement, we look into the squeeze. You can see that the patient is squeezing. This is the sphincter, and the patient squeezes, it becomes dark. So that's one thing which you have to notice. And after this, we ask the patient to strain. When the patient strains, there is an increased pressure above the rectum, and there is relaxation of the sphincter. And then subsequently we do an RAAR, we inflate the balloon and see for the reflex relaxation of the sphincter. That's my voice. I've made it a little fast. Now the patient finally expels the balloon in the left lateral position itself and you can see the balloon coming out. So these are the various normal basal pressures, normal squeeze, normal straining, normal RAAR and normal cough reflex. Cough reflex is very important. Whenever we cough, the sphincter contracts so that the contents do not come out outside because of increased pressure. So whenever this patient is having some neuropathy or there is a borderline sphincter dysfunction, the cough reflex will be abnormal. That will help you to diagnose. Right. So balloon expulsion test, most of our patient, the literature says that you have to make the patient sit in a commode and pass because that is more physiological. But what we practically see when we do the test is most of our patients are able to pass the balloon, expel the balloon in the left lateral itself with a little tug. We can see that most of the patient passed less than 30 seconds. Dr. Preeti, you want to comment anything on this? Shall we proceed? Right. Okay. So we'll go to the case 1. So 27-year-old lady, married, nullipara, hypothyroid and replacement. In 2019, she had constipation and anal fissure. She was managed conservatively by surgeon and with laxatives, and she got better. However, she continued to have some symptoms. In 2022, she continued to have constipation. There was prolonged time at defecation, sense of incomplete evacuation, and she used to try to evacuate with the help of the digits, and she used to apply vaginal pressure for stool evacuation. Clinical examination at that point was abdomen was soft. There was skin tag on rectal examination. Squeeze tone was good. Resting was, everything was good. Colonoscopy was normal. Of course, anorectal manometry, as the first step was done, was normal. So, what are your thoughts, Dr. Preeti? You want to, at this point, what will be your next point of evaluation?
If you look at the clinical features and the findings, there has been a combination of both a good digital rectal examination as well as an HRM, which both do not suggest dyssynergic defecation. However, the patient has symptoms suggestive of an obstructive defecation, and all investigations have been done to refute the presence of any other organic cause. So if such is the case, we do see this kind of population. At least about 10% of our patients have symptoms of dyssynergy, but to have normal clinical examination as well as normal manometric features. And when we see patients who are able to easily expel a balloon in a lateral position, which is actually not physiological, it is very, very unlikely that they actually have dyssynergic defecation. Such patients we actually refer for an X-ray defecography, because we have found a large number of such patients have a rectocele. Again, here this is contentious. We don't know which came first, the chicken or the egg. Did the straining lead to a rectocele? Did the rectocele cause impaction of stool, and therefore digital evacuation becomes hard? But we've actually been able to demonstrate significant rectocele in a majority of patients who come with this scenario.
So barium defecogram was done, and it showed a significant rectocele. Dr. Anu, you want to comment anything on this? Significant anterior. Okay, fine. So there's no doubts on that. She has a significant. So the next point is MR defecography. Will it give more information for the surgeon? And I'll ask the surgical perspective also, and from your perspective also. Suppose you're planning surgery for repair. Would you like to have some more information on with the help of MR, or is this barium sufficient? Both Dr. Raja Maheshwari and Dr. Shankar.
Would like to know about the other compartments. The MR defecogram can be advantageous in that.
Okay.
Actually, this profile of the patient is something similar to solitary rectal ulcer, because a nulliparous, young female, probably infertile, probably depressed. So the profile fits in with the SRUS. So anyhow, imaging shows a rectocele, but whatever that is shown in the image need not be treated.
But so she's symptomatic, no, sir?
You have to go by the symptom of the patient, and it's very, very unusual for a nulliparous lady to develop a rectocele. Rectocele is a hallmark of a multiparous woman.
Yes, exactly.
Multiple vaginal deliveries. It's very unusual for a rectocele to occur in a nulliparous woman. But anyhow, I will start with treatment with regular biofeedback, fiber, pelvic exercises, and if the patient is very symptomatic, then we will offer surgery. And as far as surgery is concerned, I think defecogram is enough. You don't need an MRI.
Fine. Yeah. Right. So we had a gynecologist examine, felt there was a moderate mid-rectocele, nothing else obvious. So finally we have a nulliparous lady with a moderate rectocele. So Dr. Raja Maheshwari, obviously it's more common in multiparous, I think because of various reasons. Dr. Shankar has examined. So when will you intervene for rectocele in these patients? Is it, can you just add on to anything which Dr. Shankar said?
I would like to add that, as Sir said, rectocele is very unusual in a nulliparous woman. It's true, but it can happen.
Can happen.
Because there is a study in which 12% of the nulliparous women have rectocele, and it is attributed to congenital reasons. Because we also see nulliparous prolapse of the uterus, and other symptoms. So if you're planning for any surgery, I would recommend you go and do the MRI difficogram, check about the status in the other compartments, before proceeding.
Okay. So, so once surgery is planned, suppose you say the patient is being taken up for surgery, what will be the options? Like, what will you, these, I'm not a surgeon, I just put whatever I read through in the usual options.
For rectocele, we do as a surgeon, we do a transanal approach. We do what is called as a modified Delorme's operation.
Okay.
The redundant rectal mucosa is excised and the muscle is plicated.
Okay.
And we augment the rectovaginal septum. So that we do it transanally. This so-called star procedure, stapled, what they use for a stapled hemorrhoidopexy, they use both anterior as well as posterior excision.
Okay.
I have not done it, but people are doing a transanal stapler excision of the redundant rectal mucosa. But we have to be careful because we do not know whether the stapler is catching hold of the posterior wall of the vagina. So we have to be very careful that at the end of the surgery, it doesn't end up in a rectovaginal fistula.
Rectovaginal fistula. Okay. Anything you would like to add, ma'am?
Actually, we believe in doing the transvaginal repair.
Okay.
And most of the times there are going to be associated relaxation. That also could be corrected if you go and do it transvaginally. But the evidence says the surgical outcome is superior when it is approached transvaginally than transanally. I think I request sir to comment on it.
Yeah, that's true. The long-term outcome is better with the transvaginal repair.
Okay. So, is there any role of physiotherapy? Because there's some weakness in the pelvic floor before the surgery and after the surgery, or if it's a smaller rectocele, is there any role of physiotherapy in this situation?
So, as ma'am had rightly mentioned, I think there is a role post-operatively that is already been established. Pre-operatively, we do have 5 or 6 articles, which is called as prehab in terms of physiotherapy. What we focus in prehab is basically not to have anything, any kind of rectocele getting worsened. That is what we try to do in a prehab. Also give them lifestyle modification by telling them to have a proper toilet positioning, and also give them some pain neuroscience education. Basically educating them about how this pain will cause limitation in their quality of life. Right. So that is what we do prehab, and in post-hab we do have around 3 to 6 months of proper rehabilitation along with exercises, which is in a structured way when we do the assessment. And that is a holistic approach. We as physiotherapists don't look only at the pelvic floor, because we have something called as length tension relationship based on that. So sometimes when we look at rectocele, most of the time what we think is Kegels. But
Kegels.
Yeah, Kegels is the exercise that we think of. But as a physiotherapist, we see that when we do Kegels, it becomes worsened for some people. So we have to first examine the patient, relax the patient, and then go for a Kegels exercise.
Okay.
What would be the interval that you would suggest between the surgical repair and starting the physiotherapy?
Ideally, it is around 6 weeks, ma'am, that we have around 4 to 6 weeks. That is what the literature says. And most of the thing what we have seen is we can actually start off mild exercises with pelvic floor around 3 to 4 weeks. But again, based on the condition, if the patient is having severe pain, we wait for 6 weeks because it needs a little bit of healing on its own.
Okay. So the important takeaway from this case is index of suspicion for rectocele must be high in a patient who has the findings which we had now. The diagnosis is established with first clinical examination of the gynecologist and also with the difficographic studies, and management, surgical or conservative, is based on the patient's symptoms and the parity and other things. So identify this place. Anybody? Nobody. Correct. It's Commode Center. It's a museum. It's a Sulabh Sauchalaya museum in New Delhi, which has all sorts of different type of commodes. You have executive commodes, all gold-plated commodes, and all those things there, right from the previous types to present types. So I thought it should be appropriate in this case. So we'll go to the next case. For a change, we'll go to a male patient now. 38-year-old male patient with constipation for a year, hard stools, prolonged time in toilet. He stays a lot of time in the toilet. There's no weight loss. He is hypothyroid and replacement. He had undergone a colonoscopy elsewhere, which is normal. So he was being treated as functional constipation, being treated with laxatives, and he has been having persistent symptoms. So, Dr. Preeti, anything else you want to add? Like he's been having further questioning. He said he was training a lot of stools and he is having digital evacuation. So clinically likely dyssynergic defecation. So I'll just quickly go to the next one. So this is he underwent the anorectal manometry. In this you can clearly make out on straining the patient is having a paradoxical response. So there is the sphincter is not relaxing when the patient is straining, and the patient was not able to expel the balloon. So this is dyssynergic defecation, and this is type 1 dyssynergic defecation. So one question I would like to ask is, at this point, is there are some patients who will show a dyssynergy type of pattern on straining, but they will be able to expel the balloon. Do we call them dyssynergic defecation, or do we have to do further tests on them? Dr. Preeti?
Up to 30 to 35% of simulated defecation can show paradoxical anal sphincter contraction with normal rectal relaxation. We do not call this dyssynergy. The proof of dyssynergy is the absence of expulsion of the balloon with paradoxical anal sphincter contraction. So simulated defecation is not the end of the process. You wait till you see whether the patient is able to expel or not the balloon.
Exactly. So that's a very important point, because there's always a confusion that what if this is abnormal and that is normal. When the patient is able to expel the balloon, it means that he doesn't have a dyssynergy. He's having a proper process. So that's very important. So what is dyssynergic defecation? It's basically an acquired behavioral problem. Like sometime during the process in his lifetime, because of some sort of insult, like some febrile illness or some other insult, which could be anything, the patient loses the coordination between his contraction of the abdominal muscles and anal relaxation for defecation. So there is some sort of a paradoxical contraction which happens, and the major symptoms are digital evacuation and prolonged straining. They don't usually come out with the symptoms. Other symptoms the patient says is they have a sense of blockade. They say that feel that the stools are coming, but they're not able to pass the stools. That's why varuvana varadu andha marudhu. So you have to dig out the symptoms from the patients. The colonoscopy can be normal. They can be associated with SRUS also, and there can be prolapse like mucosal changes also. Of course, anorectal manometry is the gold standard. So we have four types of dyssynergic defecation: type 1, type 2, type 3, and type 4. And type 3 and type 4 are sometimes combined and to say type 3. So, but the most common we see is type 1, where there is paradoxical contraction with good sphincter, with good rectal pressures. So, associations are there with SRUS and anal fissure also. There have been various studies. So, commonly we see with SRUS, because both have a similar pathogenesis. That is prolonged straining and other things. And there can also be a relationship with rectal prolapse, rectocele development, and pelvic floor dysfunction. So because of the patient spends a lot of time in the toilet, it can impact quality of life in various forms. So people keep waiting for you all the time when the patient is in the toilet. That's what happens. When is he going to come outside? So since it impacts the quality of life, we'll have to go for aggressive treatment. So what are the levels of treatment in this patient? Dr. Preeti can start off, and then we'll have the physiotherapy.
Dr. Seshadri has already elaborated whatever we generally do to treat such patients.
Yeah, you can elaborate more on that.
See, first I would say is more than laxatives and cholokinetics is lifestyle modifications. If you can first find out the reason or the precipitating factor for the actual event, in very often you will find the stressor. It could have been an acute fissure. In our studies, we have our major cause of dyssynergic defecation is type 1. More than 70% of our patients referred for ARM have type 1 dyssynergy. And if you see, at least 30 to 40% of them would have had a painful fissure episode. That is what actually incites the process. And that becomes a learned habit. So you have to unlearn it. I mean, learning a new language from an old language. So that is more important. I would put biofeedback as one. Laxatives and other things are useful provided patient actually has hard stools or lumpy stools. There are a lot of patients who have symptoms with normal caliber and normal consistency stools. So biofeedback is more important. Unlearning wrongly learned behavior, I would put it as the first preference. And then of course, avoiding distractions, which now seem to be equal for adults, not just children. Children we see, they have encopresses and problems because they're too busy playing and they're not interested in going to the toilet. Adults are more interested looking at their phones, and so maybe that is one of the reasons why there's problem with adult defecation. But lifestyle modifications, physical activity cannot be emphasized enough in patients with dyssynergic defecation or other disorders of defecation.
So before we talk about the pelvic physiotherapy and behavioral therapy, we'll just have a brief about the biofeedback therapy. So what is biofeedback? Would you like to talk about it? Tell a little about it.
We found biofeedback to be very, very effective in patients with dyssynergic defecation, be it type 1 or type 2 or 3. Essentially, it is learning a new behavior. This is ideally done with the conjunction of a doctor as well as a good technician. We have a very able physician assistant who assists us during the process. So biofeedback, basically what we do is train your muscles to work appropriately to facilitate defecation. So what is the normal response? When you strain a stool, there should be adequate push from the rectum, which is absent in a small percentage of patients with type 2 or type 3 defecation, more often in women, multipara with weak pelvic floors. But when it comes to type 1, where there is adequate rectal push, but the outside, the door is closed even tighter, that is the anal sphincter is locked even tighter. So what we need to do is allow passage of stool through a relaxed anal sphincter. So first we show a patient how we do biofeedback is, we show a patient how a normal defecation ought to look like, how a sphincter looks at. It's very easy to understand because it's all only calorimetric. There is no, specific rocket science to this. So we show patients the different colors which indicate pressures ranging from low to high, starting from say yellow to low to black to high. Show them what the band of pink indicates, that is their sphincter. Most cases it's pink. And we show them what happens when we ask them to squeeze, where it turns black, which means the pressures are getting higher. So we show them what happens when a normal person defecates. He or she applies pressure. You're seeing pink lines on the top which indicate rectal pressures, which are of adequate amplitude. And you're also showing them that the pink anal canal below now changes into say orange or yellow, which means the balloon or the stool is going to get expelled with ease. We ask the patient to repeat the same maneuvers, stay at rest, squeeze, strain, and try to attempt a balloon expulsion. And when we see the paradoxical response, we ask them to view that and then ask them to compare it to how it ought to be. So once they understand where the problem is, and believe me, most patients across all age groups seem to understand this very well, we then ask them to start learning to relax, and the main way you relax is to breathe. Breathe well for at least a period of 2 to 3 minutes, and you can see the sphincter pressures gradually decreasing to acceptable levels. Then we ask them to attempt simulated defecation with an air-filled balloon. And this we do at least for 3 sessions. Ideally, biofeedback ought to be done with a 1 week to 10-day gap, because patients are supposed to learn or practice at their homes before they come back for the second session. But it is easier said than done. So for practical reasons, we offer a day gap or 2 days gap and make it 3 sessions. By the end of the 3rd session, about 60% of patients have understood what they're supposed to do. Whether they expel the balloon with ease or not is a different question, but at least they're able to understand how to relax and they attempt to relax.
Absolutely.
And I have to say that 40% of patients will need further sessions. 3 sessions are not enough. So even most feedback, I mean most papers for biofeedback show a follow-up of about 6 months. This is very, very difficult in a sitting like ours where patients coming back for something like this is quite difficult. This is how biofeedback is done at our center.
So we generally use the available machine itself, but innovative software and all is coming in, wherein they say when the patient relaxes, it claps and they cheer and all those things are there. So it gives more motivation for the patient. These are new software that is coming. So I think this Dr. Preeti has already explained about this. So there are a variety of pelvic physiotherapies and various options for these patients which can be used in addition to the biofeedback for patients with the dyssynergia. I think Dr. Aditi Nair can explain how it is tailored and is there any behavioral therapy and other things which are going to help?
Yes, biofeedback actually can be tailor-made based on the cases that we get, because when we see a patient in stages of rehab. So initially when the patient comes, there might be certain muscles that might be hyper. So we try to relax those muscles, then go for a proper strengthening protocol which becomes functional. So when we go and talk about biofeedback, there are various types of biofeedback that comes into play. It works on operant condition, which is like nothing but a learning process. So when you give a person something which gives positive reinforcement, like Sir said, clapping, gives the patient an understanding that, okay, I'm doing this well. Then this is something that comes into a variation where you can do a visual feedback, auditory and sensory feedback, and the patient understands through all this mechanism that I have to use my pelvic floor better. Where this all comes into play is we teach the patient actually how to use the abdomen muscles properly. That is your external obliques, your transverse abdominals and internal obliques. Transverse abdominals mainly, and when you do a breathing exercise like ma'am was mentioning, that decreases the anal sphincter pressure on its own. There is also rectal sensory perception, which is a trial and error, which is not actually done in India. It is mostly done abroad, and we also, when you do all of this, there is more of muscle awareness and control. That means there is motor unit potential that gets picked up from the patient side. These are the components to a biofeedback device. So there are a lot of biofeedback devices available in the market. The basic is nothing but either you have a probe and either you have a surface electrode. There are own pros and cons for surface and internal this, and there is just when you place it as perianal, there is more of external pelvic floor that gets picked up. But when you use a probe, it is more of your internal pelvic floor, that is your grade 3 or level 3 of pelvic floor, what we speak about. And this is nothing but the patient understands, okay, there is something placed, gives a sensory awareness to the patient. From here, it is transferred to a monitor. So from the monitor, the person basically learns the behavior, and that's how we have the entire process going on.
Right. So we have one biofeedback at our disposal and also one from the physiotherapist, and I think both can be used to get the patient better. So basically our patient underwent multiple sessions of biofeedback, and he was able to expel the balloon. You could see that the balloon moving out, which was not within 20 seconds he was able to expel the balloon, and he came out as a happy man like this. Let's see if this comes earlier. Okay. So Dr. Epan talked about dietary disturbance and westernized diet leading to metabolic liver disease. So the same western toilet has been causing more dysynergic defecation. That's what we've been seeing. And actually that's been proven. The way we sit on the commode doesn't relax the pelvis well, the angle which we sit. The squatting pattern which the Indians have been accustomed to all over the years is the way it relaxes the pelvis adequately for all the muscles to relax and for the rectoanal angle to become straight also for a adequate proper evacuation of the bowel. So it's coming back to Atmanirbhar Bharat now. So this was another Indian style commode which was designed recently, which was more comfortable on the leg so that the patient can squat better. So we can see the difference in the position. No? It's 90 degrees when you sit and the 35 degrees when you squat. And so of course, we cannot get back to the habit of going back to Indian toilets in all our houses. So what we can tell the patient is keep a stool and keep your foot on the stool so that the pelvis gets relaxed like a squatting position. So I think that's very important to explain to the patient that even after training, no, he has to go back and do the same thing there and he has to follow these at home. So retraining them is very important. So interestingly, even in Japan, they have this sort of toilets. So I think they are following us. So is there any role of combination? I think it was discussed already, so we won't go into it. So cognitive behavioral therapy. See, what happened is what we saw in the pathogenesis itself is some inciting event, like a stress or something, which has caused the patient to lose his coordination in his defecation. So is there some sort of a plasticity which has happened in the cortex, which has made him defecate in the wrong way? So is there any role of cognitive behavioral therapy to stress busting and yoga, meditation, all those things, which will have an influence on the defecation control and make the patient better from the dysenergic defecation? There was a study interestingly from Iran, which said that there were favorable responses in some patients with deranged cognitive influence with the help of cognitive behavioral therapy. So this is data from our hospital, Apollo Hospital, where we see that the maximum is type 1 dysenergic defecation. And almost 114 patients underwent biofeedback therapy, and most of them were very happy at the end of the sessions. So there are a lot of innovations in commodes. No? So you can see that there are 2 commodes for couples. Those who have dysenergic defecation, both of them, they can use that. So we'll go to the case 3. This is the other extreme. So 53-year-old multiparous woman, increased stool frequency and loose stools, fecal urgency, colonoscopy done elsewhere again was normal. She was being treated as IBSD for a long duration. So what was missed and how will you proceed? Last row. Somebody? Not last row, maybe the first row here. I think they are escaping. The first row you can give. Mic illati paravalla appadi pesala. You can talk loudly if you can. What are the next questions you will ask, and quickly, I don't want to waste time. No enthusiasm. So we will not waste time and we'll go further. So I think the important questions which you have to ask these patients, they will not come out with the questions. Because the social stigma, they won't come out with these symptoms. She has been having occasional fecal soiling, and she, especially when the stools are loose. And when you go back to the history, she has had multiple vaginal deliveries, prolonged deliveries, and there has been one instrument-assisted delivery also. So clinically, with the history itself, now we can say that it is not IBSD, it is anal sphincter dysfunction. So if you can, Dr. Raja Maheshwari, can you, Madam, if you can briefly tell what are the usual causes for sphincter injury during the normal deliveries, and is there any ways it can be prevented? And what are the other pelvic problems which happen with instrument deliveries?
In fact, the mechanical disruption of the sphincters and neurologic damage both can lead on to it. In fact, the so-called uneven full normal vaginal delivery itself can cause damage to the pelvic floor muscles.
Okay.
And particularly the puborectalis muscle is prone to get damaged more. So all the more if she's a multiparous woman having delivered big baby with shoulder dystocia, with a persistent occipito-posterior position, all these things are risk factors. And supposing she had a tear or episiotomy, that can cause continuation of the disruption of the external sphincter. So normally it affects, more in the first delivery itself. The first delivery itself, the insult inflicted is significant. So particularly the instrument, the forceps delivery causes the worst damage. And if at all the instrument is recommended, it is the vacuum which is accepted.
Right.
And the episiotomy incisions, if they do the midline incision, it can very easily extend and cause sphincter damage. Mediolateral episiotomy is supposed to be not involving, it doesn't really involve the sphincters.
Right. So since it's more changed to ventus, you are seeing less number of sphincter dysfunctions of late when compared to those before, or?
Actually, it is the orientation of the obstetrician.
Okay.
So the eyes do not see what the mind does not know.
Okay.
Unless they keep all that in their mind, you will not be able to pick it up.
Right. Okay. So of course the next step was inertial manometry. In this you could see that the sphincter pressures, both the basal pressures were low and the squeeze was also very low. What we see here is that the patient is using the gluteal muscles to augment the sphincter. The line you see below is a gluteal augmentation. That is another very important sign that the patient's sphincter is very weak. So it is a combined, since the basal is weak and also the squeeze is weak, it's a combined internal and external sphincter dysfunction. So she had a EUS which showed a disruption of the muscle, and yeah. So we'll quickly go into the various options which are available for the patient is having a significant sphincter injury and incontinence because of the sphincter injury. So we'll go into the various options which are available. Stool bulking agents can be used, which can increase the consistency of the stool, make it less loose so that the patient is having better continence. Loperamide increases the tone of the sphincters, so it can be tried whenever the patient is having severe symptoms. Pelvic floor strengthening exercises and surgical repair we will come to shortly. So Dr. Raja Maheshwari and Dr. Shankar, so when will you time the repair? Early or late, and when will you time the repair, and what are the options for these patients?
The ideal timing is to repair it at the time of delivery, as soon as you recognize it. If it gets missed, naturally the patient will have all the symptoms and come to you later. So how early can you repair the primary repair? Originally we usually think it will give a gap of 3 to 6 months, but there are studies saying that you can do the primary sphincter repair as early as 2 weeks. Within 2 weeks you can do it.
Right. Okay. So before we go to the surgical options, Dr. Preeti, will biofeedback help in these patients? Which select patients will you refer for biofeedback? Will it be as effective as it is in dysynergy?
To be honest, my experience with biofeedback for fecal incontinence is very minimal. We found that if started early on, it possibly has a better outcome. What we do in biofeedback for fecal incontinence is try to augment squeeze pressures of the patient with decremental values of balloon insufflation. Keep decreasing the amount of air or water filled in the balloon and ask the patients to sustain and hold the squeeze. But my experience is honestly limited, so I can't comment on this.
Right. So that's a same thing everywhere, because we generally refer for physiotherapy. So options of physiotherapy.
So there are various things that we do as a physiotherapist. So the main one is exercise therapy. Here the Kegel's exercise is the excellent option. There is also behavioral training that we do, where you teach the patient to have a bubble diary which is kept for 3 to 7 days to understand a behavioral pattern. There are certain articles which say about neuromuscular electrical stimulation which should be started early on, and there is certain assistive devices in cases of where there is leakage present. We tell them to use the anal plugs.
Right. So I think physiotherapy is the mainstay. If the patient has had a significant injury, I think surgery has to be done to improve the quality of life for these patients. So of this full menu, which would you go for, sir?
Once the indication of surgery is established, we are convinced, then we go for usually the anterior approach, the anterior levetroplasty. Only thing is we have to make sure that we don't make a buttonhole into the anus or rectum, because that will convert into a fistula.
Fistula.
As far as if the sphincter is very bad, then we have to do a augmentation with the gracilis muscle.
Gracilis.
But I don't have any experience regarding dynamic graciloplasty, where this muscle is
directly taken
continuously stimulated to convert into a different type of muscle. What we do is just we do an augmentation, non-dynamic sphincteroplasty, graciloplasty.
Okay.
You can use one gracilis, you can use both the gracilis, so that can be done.
And the outcomes are good?
Yeah, graciloplasty outcomes are good.
Outcomes, okay, fine. So there are other experimental therapies and costlier therapies like stem cell, which is the work for everything else, but these tools have not yet come into full action. So I think we'll just quickly go through. Rectal prolapse, 2-3 questions. Dr. Anu Ipen, any additional information I think you've discussed about it, so I don't want to. The information about from ARM and rectal prolapse, sometimes there can be sphincter dysfunction because of repeated prolapse.
No, if the patient is having a complete rectal prolapse, I don't think there is a need for a defigography.
Okay.
Defigography has a role.
Small, lesser ones, yeah.
If you have an internal prolapse, the prolapse is coming up to the anus and not coming out.
Yeah, when it's out, it's obvious.
If the prolapse is coming out, there is no need for defigography.
Defigography, yeah.
You can do a colonoscopy and evaluate
the
colon.
That is in the earlier this one.
Another point for the students is rectal prolapse is one condition where if the patient gives history of mass coming out of the anus, you'll have to go to the washroom with the patient and make the patient squat and ask him to strain. So then only you can diagnose rectal prolapse. Otherwise, you'll not know whether it's a prolapse, hemorrhoids, or a rectal prolapse. That's one examination you'll have to do in the washroom of the patient.
Okay, right.
Regarding the association of rectal prolapse with the other compartmental prolapse, there is a study in which 480,000 women were studied. In that, there was only 2% of combined rectal and pelvic floor problem. But when the rectal prolapse cases were taken into consideration, but there were nearly 20% of the cases, those who had rectal prolapse also had a prolapse in the other compartment.
Other compartments. So what will be your surgical options, sir? Quickly, it's rectopexy or anything beyond that?
Quickly, the gold standard of treatment for rectal prolapse is resection with rectopexy.
Resection with rectopexy.
That's as the highest, because if you take the number of surgeries for rectal prolapse, more than 200 procedures have been described. That means none of them have stood the test of time.
Okay.
So resection rectopexy is the best treatment. But only thing is resection, anastomotic leak, all those things.
All those things.
Only thing is when you treat a rectal prolapse patient, if the patient has a severe constipation, you'll have to go for a resection with rectopexy. Otherwise, if you just do a rectopexy, that will aggravate the constipation. There are two approaches, abdominal approach and perineal approach. You can choose whatever you are comfortable.
Okay. So last 2 points about pediatric constipation, and then we stop. So single important test in pediatric ones we see is a rectoanal inhibitory reflex. So children who are referred for constipation, Hirschsprung's disease, suspicion of Hirschsprung's disease, in the appropriate setting, absence of RAR means Hirschsprung's disease. So just 2-3 points, because it's a real problem which we say. So what is the trend of defecated disorders in children, madam? You see in the mic. Mic. I think this is the last one, and then we'll be completing with this. Because I thought this is very important, because we see children at the right from the time of toilet training, the children are sitting in the commode with the phone now. So what's the influence of that, and what do you see, and how can you train the parents?
Actually, the parents are very anxious. That is one of the reasons for the children developing all this problem, because they read lot, they go into their Google, they read lot about toilet training and things like that, and they come and want to practice all those things on the one and only child they have. So that becomes a problem nowadays. But only thing, what nowadays, you should not, the latest teaching is you should not hurry up with the toilet training. Toilet training is it's a gradual process. It should be very, very, as you said, for other things, it should not be a painful for the child. It should be a very gradual process. And not every child will attain toilet training at the same time. That you should understand. One child might attain early. That is the neighbor child has attained toilet doesn't mean that your child also should attain. It will take their own time. So everyone will have their own time. Now, previously we used to rush up. Now they say you start around after 18 months. Don't start anything before 18 months. And around maybe around 2 years, or sometimes even for them even take up 3 years. For complete toilet training, they may take even up to 3 years. So better wait and be patient. And only thing nowadays schools insist that the child should be toilet trained before they're put into school. Such things will be there. But anyway, you should also tell them that it is not a must. Sometimes for some children it's really gradual and it takes some time.
Okay, thank you. So I think that finishes it. Role of behavioral therapy, I think we discussed as we went there. So it's short of time. So summarizing, I think defecated disorder is a real problem. I think proper good history is very important, and recognition of disorder is very important to for appropriate management and improvement of quality of life. That's why I said Aram Seiya Virumbu. Aram is anorectal manometry. So that summarizes everything. So Jai Bharat. Thank you. Dhanyavadan. Not yet over. Welcome to Madurai for Tnisg Jan. We can go for dinner now. So we are coming for dinner, we can tell them. Okay. So these are various references. I thank all the panelists. I'm sorry. In the excitement, I just walked away. Dr. Anuipan, Dr. Preeti, Dr. Shankar, Dr. Raja Maheshwari, and Ms. Aditi. Thanks a lot. Thanks a lot for coming all the way. Thank you very much. And thank the chairpersons. I think excitement goes on. And Raja Yogesh, Dr. Ubali has been the pioneer in anorectal manometries. I don't know how he interpreted with all the lines. It's so easy with the colors. It would have been a real difficult one. And Raja Yogesh does all the manometries in Mid-India. And thanks, Doctor, for the pediatric inputs. Thank you.
So I'm sure we had a good academic session this evening. At the outset, I would like to thank everyone over here who made it possible, and particularly distinguished speakers from out of this society has come and honored us. So I will request Dr. Nirmala to honor Dr. Anuipan. I invite Professor Sumati to honor Dr. Raja Maheshwari, Madam. I will request Dr. Hema Vijayalakshmi to honor Ms. Aditi Nair. Thanks once again for having a difficult topic made easy for all of us. And I would like to thank our patron, president, secretary, and distinguished ISG members and postgraduates. And we'll meet again in Madurai for our state conference. And those who have failed to register and scan the attendance form, please do it without fail. And it's time for dinner. Please join us for the cocktail dinner. Thank you once more. Sorry, I'll thank Torren for the ambience. Sorry, I missed it. Thank you.